Morning, everyone. We're just going to give everybody another couple of minutes and then we will get started with our introductions. And just as you're joining, would you mind putting your name and what you do in the chat so people can see that? That would be lovely. Thank you. This is where it starts pinging. Just give everybody a couple more minutes, Abby, and then we'll get started, I think. Just while everybody's coming in. Okay, it's 9:02. We'll get started. I'm sure people will continue to join us as we go round and welcome everybody. So good morning, everyone. My name's Amanda Stanford. I have the privilege of two things. One, I have the privilege of working at Airedale Foundation Trust as the Chief Nurse and Exec Director for Midwifery and Allied Health Professionals. And I also have the privilege of being the Senior Responsible Officer for the Better Births programme under the Actors One across Bradford District Place. And oh, can everybody put themselves on mute if that's all right? That's lovely. A little bit of echo, apologies. And have the absolute privilege of working with Abby Wild, Amy Tatum and the Actors One team who are with us this morning. So I'm just going to ask our team to do a little introduction so you know who they are. We obviously won't go around everybody. For those that have joined, what we've asked is that you just put your name and what you do in the chat so people can see. So I'm going to come to you, Abby, first, if that's all right.
Hello everyone, welcome. My name's Abby Wild. I'm the Programme Manager for the Actors One Better Birth programme and a midwife by background, and I'm really pleased to see so many people here today. Thank you for joining.
Amy?
Good morning everyone, and welcome. My name's Amy Tatham. I'm a GP in Bradford, and I'm also an Associate Clinical Director of Maternity Care and Women's Health across Bradford districts and Craven CCGs, and I'm also the clinical lead for the Better Births Actors One programme. Thank you.
Lovely. Eugene?
Good morning, everybody. Great to see you all. My name is Eugene. I'm a project support officer for the Better Births programme, so here just to help.
And Kate?
Good morning, everyone. I'm Kate. I'm the Programme Administrator for Actors One, and again, here to help this morning and listen and learn. Thank you.
Lovely. And I think we have our Programme Director, Mark Hindmarsh, with us as well. I think I've seen his name pop up. Morning, Mark.
Hello, Amanda. Hi, everyone. Yeah, welcome, everyone. Yeah, so I'm Mark Hindmarsh. I'm the Programme Director for all the Actors One programmes, of which this is one. So yeah, welcome along, and looking forward to the morning.
Great, lovely. So welcome everyone. Just to kick off, really, to give a little bit of context to this. So Better Births started a couple of years ago now, and right from the very start, one of the key things for us as a team was really to focus on health inequalities, and Amy has led that work stream for us, and we started to focus originally on sort of the digital inequalities, and clearly over those last couple of years, nationally and locally, that topic has become increasingly important. And as we have seen evidence being produced around the gaps between health between different groups, I think it's become probably one of the most important things that we felt as a Better Births group we needed to focus on. And this conference this morning helps us, hopefully will help us shape some of our thinking. What we want to try and do is shape what we're going to focus on over the coming 12 months, 18 months, and how we're going to address some of the health inequalities across Bradford District Place, linked in clearly with the local maternity and neonatal system, which is also focusing on health inequalities. We're really excited as a team that there has been an announcement around the national task force, so clearly some of what we do will be shaped by what comes out of that, led by Jacqueline Dunkley-Bent and one of the MPs. And so with that, I am going to welcome everybody. I hope you enjoy it. I hope you get as much out of it as we are looking forward to getting out of it. I'm going to hand over to Abby, who's going to take us through, hopefully, the morning. Abby, if we can just go through the agenda, and then Abby's going to introduce our first guest speaker. And we have a Menti meter that Abby's going to just talk through too. So Abby, over to you.
Thank you, Amanda. Eugene, would you be able to share the agenda for us, please? Everybody should have access to this agenda. It's in the link to the meeting if you want to have a look at it throughout the morning. We'd really love you to join the Mentimeter so that you can interact with this event. You know, we're hoping to take all of the information that we get from you this morning and bring that forward, like Amanda said, into the health inequalities work stream. So please do join in. And if you have any questions, you can pop them in the chat as well. And if you would like to speak, obviously raise your hand and we'll try and get round to you. So here's the agenda. And our first speaker of the day is Zara Khan. We're really excited to welcome Zara. Zara is a midwife researcher and a teaching fellow at King's College London, and is the author of the headline article in the British Journal of Midwifery, Ethnic Health Inequalities in the UK's Maternity Services. Welcome, Zara.
Thanks, Abby, and thanks, everyone. Would you like me to share my screen, or are you going to continue with the agenda, Abby?
If you're able to share your screen, that would be great. If there's any issues, just let us know and Eugene or Kate can help.
Perfect. Thank you so much. Let me just share my screen with you all. Can you see that clearly, Abby? Perfect. Will kind of disappear as I'm sharing my screen. So if you have any questions or you can't hear me, just please shout out. So thanks again for inviting me, Abby. It sounds like there's great work going on, and I'm here to talk about a piece of work that I undertook based on ethnic health inequalities. Just a little bit about me. As we mentioned, I am a midwife, and the piece of work that I undertook was as part of my master's thesis and was then published a few years later in the British Journal of Midwifery. And by background, I'm also a lecturer, a researcher, and now also a PhD student. I thought it was really important, especially for this event and giving context, to talk about what a health inequality actually is. I'm mindful that people joining this call have probably a different understanding or different backgrounds. So health inequality is essentially differences in health status or distribution of health, and that can be between different population groups. Now, health inequalities can exist between countries, within countries, but also within and between different societies. So that could be street to street, borough to borough, region to region. What's even more important is that health inequalities are often preventable, and they are unjust differences in people's health status within and between different societies. They're often a result of different social and economic inequalities starting quite early on in life, and we can see and measure them based on rates of disease. It can be outcomes, experiences, or other wider social determinants of health. So it's important to understand that essentially there are differences in people's health status, which is then what I aim to look at. And why ethnicity then more specifically? So ethnicity, which is defined by people that belong to a certain social group, they have shared cultures or traditions or ancestry, which then shouldn't be confused with race. Race is a social construct which was based on physical appearance alone. So ethnicity as a measure, ethnic groups, it's important to know, are amongst the most disadvantaged groups in the UK, and they also face lots of different social and economic deprivation. So that can be anything from housing, unemployment, education, and multiple forms of inequalities that are spread across our society. This then also leads on to having poorer health. Structural racism embedded within society or organizations based on policies or rules or laws can often reinforce these inequalities. So essentially it's leading to people having an unfair advantage or disadvantage in society. And there's lots of literature available based on racism and discrimination, also on basis of ethnicity, and that's shown to have a negative impact on people's physical and mental health. There's lots of literature, particularly in the States, but there's a growing body now also in the UK as well. I just wanted to take a moment to talk about terminology. I think it's quite important when we're talking about ethnicity and different terms that we're using, because everyone feels quite strongly about different terms. So the term BAME is often quite widely used in government papers, also this review too, and it was an accepted term for quite a while. However, for those that are unaware, from 2021, so last year, it's recommended by the Commission of Race and Ethnic Disparities and the RDU that we stop using the term BAME because it has lots of limitations. Ethnicity is not homogenous, and we can't refer to them just as one group. There's lots of different variables involved in that. However, currently there are 18 categories that we use to define ethnicity, and that was used as part of the search strategy for this systematic review as well. So I do acknowledge that it's quite limited, and would encourage that going forward people use the correct terminology. So what do we know right now about health inequalities and ethnicities in maternity? So I'm sure it's not news to anyone here that there are differences in health outcomes between the white British population and all other ethnic groups in the UK, and they can be seen in outcomes that I've listed. So for example, neonatal and maternal mortality, low birth weight, stillbirth, preterm birth, which all have negative consequences on our morbidity and mortality. And it also then leads on to health inequalities later on in life, so from early childhood all the way up to our life course. So we know they are present, but why did I then undertake a systematic review? So at the time of undertaking this, there was some literature available, but there wasn't any clear evidence about the current state of maternity services. The famous Embrace report that I'm sure we're all aware of, which highlighted the ongoing inequalities in maternal mortality, was published later in the year. However, we knew from previous reports that there were disparities in mortality. It was just not kind of in the public domain or highlighted as much as it has been in recent years. So I wanted to be able to gather all the available evidence and try to present that in a clear way. And I wanted to explore these inequalities in relation to experiences and use of services. So all of the studies included were between 2013 and 2018, and lots has changed since this work was undertaken, especially with the pandemic. And as I said, now there's a growing body of literature around ethnicity, which is fantastic, and also research that's currently being undertaken right now. And that's kind of COVID related and non-COVID related. So I did an inductive thematic analysis, which essentially means that the studies included didn't aim to look at health inequalities specifically, and it was not, a term that was as popular as it is right now. Rather, the analysis itself helped generate these themes. So the data and information that I saw helped determine the themes that I then found as part of this review. So I whittled down to 8 studies and 5 different themes. From these 8 studies, they all looked at different populations from different cities, included different ethnic groups, but interestingly had similarities in these themes. You can see some themes are more prevalent than others. Quite notably, services and systems was a recurring theme, and second to that, communication and midwife-woman relationship. So I'm going to just talk a little bit about each theme. I won't be able to go into a great deal of detail, but I'm sure this will come up in the discussion. So communication as the first theme. Now, communication was often an oversimplified issue relating to people's language ability of having English proficiency or not, and that is the reason why people weren't able to communicate. However, there were other forms of communication that were also impacting people's experiences and care. So, for example, non-verbal communication as well. Things such as medical terminology that really limited people's understanding, and it didn't matter whether they had below average English speaking ability or above average English speaking ability. There were differences in how women from different backgrounds expressed their symptoms, And then this was often misinterpreted by midwives and led to a delay in treatment and sometimes misdiagnosis. And that was particularly around mental health symptoms. And also then a poor active listening skills. So women reported feeling dismissed, and a word that was used quite often. Midwife-woman relationship, I'm sure the midwives here can agree, that's a really important component to our work, is establishing good relationships with the women that we care for. And unfortunately, there were kind of differences in expectations of each other. So that was from midwives that were interviewed, but also women. So midwives tended to take quite a holistic approach, whereas some of the women that they cared for preferred a more kind of a task-orientated relationship, or they were not used to having a midwife as the lead carer. Instead, they were used to, in their home country, having a doctor, for example. So there was a difference in expectation there of each other. Negative experiences. So previous negative experiences really impacted the ability for positive new relationships to be formed with midwives. And some of those experiences that were then negative often left women feeling again dismissed by midwives or other healthcare professionals. Whereas if a woman reports having a good interaction with their midwife, this overall resulted in a positive experience of pregnancy, labour and the postnatal period by women. So it was really important to them. And midwives themselves also found it hard to establish relationships with some women, and that was based on cultural factors, which kind of cut across the culture theme as well. So I'll touch on that on the next slide. So services and systems, which are essentially any logistical or organizational structures that potentially contribute to inequalities. And some of these will not be a surprise to many of us. So things like short appointment times. This created barriers for women due to time pressure. There was kind of a lack of flexibility. There was lack of flexibility from interpreting services as well. Midwives also found interpreting services difficult to access, especially in urgent situations, which meant that often family members were used to interpret instead. And women reported that poor interpreting services often meant that there was a delay or a postponement in their appointments, which overall affected their perception of their quality of antenatal care. What would be considered poor engagement and non-attendance was seen as an avoidance tactic by midwives. But this was a misunderstanding, as often it was due to things like domestic commitments, a lack of interpreter, and not understanding any written information about appointments, and also at times due to travel too, which is kind of where the lack of flexibility for appointment times also comes into that. In terms of late bookings, a lot of women were unaware of the importance of a booking before 13 weeks gestation, and this was predominantly down to a lack of information, usually from the GP, unfamiliarity with the UK's health system, and not being oriented to maternity services generally, or in the UK if they were recently migrating. Persistent staff shortages, again, not a surprise, but the time constraints in the services overall meant women's expectations of support, because there were fewer staff, were often not met. And again, this led to feelings of isolation, particularly with vulnerable women who had mental health needs. And when it came to culture, midwives noted how some cultural and religious practices contradicted their advice or policies, and this then left women and families feeling dissatisfied by the overall service provided. So there was kind of differences in understanding. There was also comments about culturally appropriate services. So this was around antenatal classes and some women not feeling comfortable if males were in attendance in the classes. Midwives who did not report positive relationships with women often judged women more harshly compared to women who were able to establish a relationship and then reported having overall really positive interactions with women. And for some women's requests were often seen as burdensome. So this could be things like requesting to have a female doctor instead of a male doctor. So that then again goes back and impacts the midwife-woman relationship theme. And then lastly, social needs. So for some of the studies included, immigration status was associated with non-attendance. So women feared being alerted to authorities and being risking deportation. And complex needs of women often led midwives to feel quite frustrated and did lead to some stereotyping as well. So things that we're aware of that we've probably seen in our practice as well, and some things that are quite difficult to hear as well. But what can we actually do? So I offered some suggestions of what we can do. So although, you know, all themes are important to consider, one that stood out most to me were services and systems where we have kind of organizational structures that can be changed, and they then overlap with the other themes. And if, you know, we're able to tend to that, hopefully it will kind of lead into the other themes as well. Midwives themselves need flexibility, they need the time, they need the resources in order to kind of fully complete the role that they want to undertake, and are often then pressured by the services and systems and therefore not able to meet the women's needs. Fit for purpose services, particularly for interpreter services, I think it's really important that we can integrate with local communities to understand their culture and religious practices as well. Orientation to maternity services, again, something that can be resolved through the services and systems theme. So women, and this is not just new migrants, but all women really understand what to expect from the services. And then lastly, just to listen to women and midwives. I mean, they're the ones that are the most affected by this, and midwives want to be able to provide you know, the care that is both fulfilling for them and the women, and vice versa. And we really need to be proactive when we hear what their needs are. Thank you very much. That was a quick tour of this systematic review. That would be great if we could have questions and have a discussion. Thank you.
Thanks, Zara. Let's open that up, and if anybody has any questions, if you can put your hands up, then we can bring you in. I can see hands up then. Zara, that was fantastic. Just while we're waiting for people to be brave enough to put their hands up and see who's going to go first. If not, we can have a look. I think, Abby, we can pull up the Mentimeter and bring up. So, Zara, I'm going to kick off the questions because this has been a real ongoing discussion for us across Bradford District Place, not only for maternity care, but for lots of other reasons as well. And it's a theme that runs through all of our programmes, but it's quite stark now in maternity care. It's becoming really evident that we have got a lot of work to do. From your research, where do you think are the key areas of focus that would really have an impact? Because for me, there's something about how do we stop doing what we normally do, because we've got to do something different now, I think.
Yeah, I think when you're really embedded within a particular institution or service, and you know you're trying the best you can from your perspective, it's really hard to see where you're going wrong, or you might be doing some things that are great, but there are areas of improvement. Which is why I think it's so important to hear directly from women and midwives And this could be, you have your own kind of local working group, and you have volunteers that are able to review policies, for example, or, practical things such as orientation, something, we may take for granted because we know the services and we assume people know how to use the services. But, not all women have been through maternity service before, and it's a very different service compared to other health services in the NHS. So things like that, practical suggestions of how we can make improvements, and it's then specific to your local population. So where you are, your population group is going to be really distinct compared to where I am in South London, for example. So I think that's a place we can start and then grow from there on.
Lovely, thank you. We've got some hands up, and so I'm going to bring in Natasha Allen as our first question. Natasha, welcome.
Thank you. Fantastic presentation there, Zara. Really, really good work there. I'm one of the project lead midwives on the transformation work, and I've been leading on the maternity equity strategy for Bob LMNS. So this is all very much topical work that I've been looking into, and the more I read and the more I learn, those themes are just so key, aren't they? And I think unless we start to really address that, the health inequalities and the unconscious biases within maternity systems, I think we've got a long way to go before we can try and achieve much more, because we need to understand what's wrong within our system, not actually look at those communities and put blame on them. And I think it's that difference in health promotion and health work, isn't it? And it's fantastic that work you've done there. I'll definitely be reading up on some of those articles you've shared. Thank you.
I think you've hit the nail on the head then. It's often a culture of blaming others. So it's the women that don't understand, and it's we're putting the fault on them, whereas I think we are now shifting to looking more inwardly and seeing, well, actually, where can we make those improvements? And some of the themes that came across, they're hard to hear, because as midwives we really want to make a difference, whereas that's not necessarily the same for all women's interactions. So unconscious bias is really important, and it's self-work. An organization can take part in that, but it's also self-work as an individual in society that we need to address. And it's hard, it's really hard, but we need to do it.
And Zara, there's a question here. The Mentimeter is going potty, so there's lots of questions coming in, and there's one that talks about recruitment and what your research, how we should apply that to our recruitment practices, which is really interesting, isn't it? And how we take all of this right back to the beginning and embed it in everything we do. And I just thought that was quite a relevant piece to what you were saying, particularly around that unconscious bias. And
yeah, do we mean recruitment of midwives? Of midwives? That's a really interesting question, because it happens both recruitment of women into research, but also recruitment within maternity services. I think I can speak from also a personal perspective in terms of culture and people coming into professions such as nursing and midwifery. It's the culture's perspective of what that profession actually is, and that means that's very different in different countries. So as midwives, and I know some colleagues have gone into schools, for example, to speak to students about what midwifery actually is, and generating interest in their own kind of local community. But those that are already within the profession, I think there is importance in seeing people that look like you in positions of power, and of course everybody's getting there through merit, but visibility is really important. And where you don't have that, I think it's important to mentor and see where people want to go in their career progression. It might be something people are not interested in. They're very happy being a band 6 midwife on the front line. That's absolutely fine, but others are not, and that might be support in education, further education, which has been a stumbling block for many midwives. We don't have really we have really niche funding, for example. People have families and life commitments. You can't necessarily afford to go into further education again. So support from an organisation around that would be really helpful. And gradually there will be a shift going forward in terms of recruitment.
Lovely, thank you. Now, I just wanted to check, because Katrina McIntyre, you had your hand up and it's gone down, and I wanted to check whether you wanted to come in and ask a question.
Yes, I am. Sorry, I did miss the first half of your presentation. I was having IT issues, but I'm here now. I was just thinking about around interpreting services. This is something that in my trust we have a lot of difficulties with, and it might be the same for other trusts. So we have telephone interpretation services. I've been looking after a lady now who's 29 weeks pregnant, and it's only for the first time for this 29-week appointment that I've just been to that I was even able to access someone who spoke her language. And obviously I've had to provide her antenatal care prior to that, and she literally doesn't speak any English. She can say hello to me now and goodbye in English, but you know, this has taken since her booking appointment to get to this point. And other than day-texting the fact that I'm not able to access an interpreter, you feel like you're hitting your head against a brick wall, and I'm just not sure what we can do about that when we can't even access these services in the first place. They're supposedly there, but they're not. So because they're there, how do we get them when they're supposed to be there? I don't really know. And even when you speak to managers and things, it's like, oh, try a different day, or maybe you'll have to have a man, when actually it's more appropriate that she has a woman interpreter and things like that.
Yeah, and these are, you know, real life examples and real life struggles from both women and midwives, which is where unfortunately, you know, and I use the term on purpose, where structural racism comes into play, and it's really difficult to hear, but when your overall structure in a system, and this is the NHS, it's, you know, this is our primary health service, it's not fit for purpose. It's not new that we have people that cannot speak English, or English is not their first language. So why have we as a health system not made this change already? And the midwives and the women are then struggling, and you know, even management within the maternity services, you're very limited too, because you don't have power over that. So it's at a much higher level where the NHS and our government need to realize this is going to have detrimental effects on people's health. And you know, it literally is life or death for some women, and women that have died in, if you look at the Embrace reports, some women did not have English as a first language, or were not able to speak English. So I don't think it's something you can really solve, unfortunately, on a day-to-day. It's something that other people that are on a much higher level need to act on really urgently.
Is there anything you could suggest? Is there something that I should be doing, like when I go back to work, to say, you know, this woman, she's not had good care, I've given the best care I can with the resources I have, but it's not good enough. Like, how do we escalate that?
I think escalating, so apart from your usual day text, is, you know, your maternity matrons need to be involved, the head of midwifery needs to be involved, because how are you going to effectively provide care for this women and other women that would be similar, I'm sure, in your local community patch, in order for people to take it more seriously? And again, I'm sure it comes down to time and resources and finances, because it seems like this woman needs you know, a more joined up plan of having an interpreter available for her for these appointments. So it requires a lot of organisation as well, but it can be done. It's just the interpreting services themselves are really, really costly. So we have to look at who our providers are as well. Again, something that needs to take place at a much higher level in the NHS.
Thank you.
Thank you, Katrina. Thanks. I'm going to bring Amy Tatham in. Amy.
Hi, Zara, that was a brilliant, really inspiring presentation. Thank you. And it's really interesting to hear about all the research you've got you doing. The information that you're talking about interpreting services is really interesting, isn't it? And looking at how we can improve that midwifery and patient relationship in order to clearly help outcomes. And I think I just wanted to really echo what the previous people were saying about it's really important, isn't it, that we try and look at specific ways of how we can improve the services that we give. Did your research bring up any specifics about effective interpretation services? For example, I know that we had a presentation in the maternity meeting recently about using iPads as virtual interpreting services that are easier to access on the wards. But I understand that that's not quite as personable, is it? Sometimes as actually hearing someone's voice on the other end of a phone or in person. Has your research shown anything about what's the most effective way of interpreting?
Not specifically, no. I know there was a lot of struggle when it comes to contacting interpreting services, and that's a lot of kind of telephone interpreting services that are available to us in the NHS. Having an in-person interpreter kind of is the most optimal way, that we could utilize. There is a shift more in terms of kind of digital software that we can use. I don't think it's fine-tuned enough yet. Even things like Google Translate, which is not as accurate, and information is then held by a third party, so it's not secure and encrypted in that way. But I don't, if we're moving forward with digitization in maternity services, it could be a way, particularly for community midwives or anyone that needs to access interpreting services urgently. So in emergency situations, we can utilize, but I think, a lot of work would be required to make that fit for purpose again. But it's unfortunate that even the current interpreting services are not fit for purpose either. So yeah, I wouldn't know how to answer that in a more direct way, unfortunately. But an area that needs to be improved.
Yeah, thank you.
And Zara, we've got one more hand up, and then I'm going to draw it to a close, if that's okay. So Lila.
Thank you, Zara. I'm just trying to do the camera. Thank you, Zara. That was absolutely fascinating, really useful presentation. And it's just a comment to say how refreshing it is to hear the word structural racism. And I think it's the implication for policy drivers, especially in terms of recruitment. If we look at our demographics in Bradford, our South Asian communities, our Black communities, and women and families do like to see that reflected in terms of the staffing. So I think it's just a massive policy change and driver around the recruitment. And that is absolutely huge, isn't it? I think we do hear women's stories and parents' stories quite regularly. But the implications are absolutely huge. But just to say, it's good to hear that term used. Thank you.
Thank you. I think integrating with community services again plays a huge importance, because not only are you understanding their kind of religious and cultural practices, you're becoming more of a norm and kind of a familiar and trusted profession to them. It makes younger people more interested in the profession, wanting to come in and be recruited and work within their local communities, which I'm not saying should resolve the issues around things like communication and language, because again, it's often oversimplified to just not understanding English, where there's lots of other nuances towards the communication and interactions we have with women. But it's one step forward. It's one step forward. It's one angle that you can take. And yeah, it is hard to hear the word racism, but I think we just need to be transparent and say it like it is. And that way, hopefully those policymakers and those kind of leading the NHS and the government will take this seriously. But thank you, Leila.
Zara, thank you. I'm going to bring it to a close just with a recognition. There's a comment in the chat that I think, whilst we don't have time today, is certainly worthy of further exploration at some point. And it's comment from Caroline Granger around how we use our assets rather than a deficit model, and how we look at what is strong rather than what is wrong. And that feels like the right principles, Zara, to base whatever we do in any area that we work going forwards.
Yeah, I agree. And, you know, there's lots of things that we are working on, and as a profession, we are really good at, you know, if I can say, even compared to some other healthcare fields, we are really good at some things, but there's always room for improvement, and listening to midwives and women is really important when it comes to that. Thank you for having me.
Thank you, Zara. That was fantastic. Abby, I think just before we do move on, just to say there's so many questions in the Mentimeter that we will pull those together. Zara, if it's all right, we'll share those with you and get your comments back, and we will share those out at some point after the conference, and we will also make sure you've got the links to the systematic review that Zara did. So thank you. Abby?
Thank you so much, Zara, and thank you everyone for interacting. We will try and get those questions out and answered and sent out to you with all the links. So our next speaker is Sheena Byram. We are honoured to be joined today by this internationally renowned speaker. Sheena has been a midwife since 1978 and co-leads the Midwifery Unit Network, and in collaboration with her daughter, who is also a midwife, runs Byram & Byram, The Practicing Midwife, and All for Maternity. Sheena is the author of the best-selling memoirs Catching Babies. I know lots of the midwives out there will have read this, and co-author of The Raw Behind the Silence, Why Kindness, Compassion and Respect Matter in Maternity Care, and Squaring the Circle, Researching Normal Birth in a Technological World. Welcome, Sheena. Thank you so much for joining us.
Thank you for having me, and I'm delighted to be here, and I feel really honoured. I'm just going to share my my slides. Let's hope it works. Here we go. Can you see that?
Yes, it's not in full screen view. It's
oh, just one moment, and I'll make sure it gets there. Can you see okay?
Just got a white screen at the moment, Sheena.
Can you see anything now?
Would you like Eugene to share for you?
If possible, because it doesn't seem to be working. Sometimes this happens with, oh, brilliant. Thank you so much. Actually, Eugene, that's not the same presentation. It's not the right one, sorry. It's, oh, that's it. Brilliant. Did you just refresh it? Thank you so much. It'd be fantastic if you could change my slides for me. Thank you, Eugene. So, I'm Zara, that was a fantastic presentation, and to follow you is really important because a lot of my messages kind of build on what Zara's just said. So thank you so much for presenting your paper, Zara. Eugene, would you go to the next slide? Thank you for, thank you again, no, sorry, the previous one. Thank you for inviting me today to speak about this important topic. One of the things that I was involved in as a consultant midwife many years ago was my role was in public health, and it was to work very closely with communities who were disenfranchised in any way. And I worked in Blackburn, which many of you will know, Blackburn and Burnley in Lancashire, and worked very closely with South Asian populations. And a lot of what's being talked about in Zara's presentation was things that we were focusing on during that time. And it was about 12 years ago. And I learned so much. And I loved the fact that someone brought up the the issue of looking at assets rather than risks, because whilst we have to acknowledge risks, I think there are so many assets and so many positives through working and finding out the power of populations that are maybe a little bit different from ours, and culture from white British culture. So thank you so much for inviting me. Next slide. We've got a lot to contend with at the moment, haven't we, in maternity services? And you know, we've kind of facing the issues of racism, systemic and individual racism across many levels. We've also got gender issues, we've got climate change, we've got a war going on that's very close to us, and we've got the pandemic. And the reason why I wanted to share this slide was because all these things impact on what we're doing in maternity services, and actually all these things impact on each other. Next slide, please. One of all the things that I'm going to mention, what I'd like you to keep in your mind is the fact that women from Black and brown communities and populations from those communities are actually witnessing these issues that we're having, these constraints at the moment, double-fold. So they, whatever the population in general feels and is seeing, Black and brown families that we're serving feel this even more. So the too little too late, too much too soon agenda, where there's too much intervention in some areas and too little in others, is actually impacting greatly on this particular population. If you could please change the slide, thank you. So, for example, do you know traumatic birth? Reporting of traumatic birth is ongoing, and this, whilst this is an old reference, we're still hearing from women and families talking about their poor experiences, or even more so from communities, from minority communities. Next slide, please. We have to be cautious as well, at the same time as hearing about the fact that these stark statistics that appear consistently within the media, and we have to acknowledge that this is an absolute needs addressing urgently, and it's ongoing, and it will continue to be ongoing. But we have to be cautious as well, because many of the people that I work with from Black and brown communities tell me that it's making them afraid. Their fear is becoming greater. So how can we do it without increasing fear? And not to over medicalize people that are from Black and brown communities, because sometimes we can do that in a way that's still very patriarchal. It's still full of colonialism. And you know, a Black woman who I work really closely with, Anna Horn, has just brought this to my attention, the fact that, you know, the new screening device that's been introduced, you know, technology is not the root cause of racial health disparities, and we have to, you know, not think that that's a solution all the time. So keep looking at the ways that we can address these issues without being too demonizing. And you know, that's where the asset model comes into play, and it really resonated with me. Next slide, please, Eugene. Thinking about the midwives too, as well as the underrepresentation, you know, midwives from Black and brown background communities are feeling worse than ever in terms of, if you could move the slide on, Eugene, in terms of the staffing crisis. You know, already we were seeing that those midwives were underrepresented. They weren't getting the same acknowledgement as white midwives, and you know, that is an absolutely big issue that's just been mentioned by Zara too, and I'm seeing that all the time. Next slide, please, Eugene. So just quickly to share this, that, you know, we know that midwives are leaving. Midwives are feeling burnt out, stressed in practice. Doctors are too. So I should have said at the beginning, whilst my presentation focuses on midwives, it is really about everyone. This is about everyone that's working in healthcare services as well as maternity. And doctors are telling us that they're actually practicing defensively because they're burnt out and short-staffed. So imagine how they'd feel, how doctors and midwives and nurses feel that are from underrepresented groups. Next slide, please, Eugene. Sorry, I have to keep saying that. So we have to have a call to action, and that's what this day is about. Next slide, please. So the very first step, next slide, is that we have to think about the value of midwives. And I'm particularly focusing just for the next few slides on midwives, because very often it's overlooked, the importance of the worth. And these are, I'm not going to read them out, but these are some of the outcomes that have been published in the Lancet to show, demonstrating that the impact of midwifery is huge. So we have to look after the midwives as well as the doctors and the healthcare assistants. But because they've got this huge impact, that it's really important that we recognise that. Next slide, please. This is a global phenomena, so right across the world, the outcomes can be improved for both mothers and babies and families and societies and humanity itself if we have enough midwives. Next slide. And in the community, in communities, so the COVID-19 has demonstrated absolutely that primary care health is crucial for reducing health inequalities, and that midwives play a huge part in that. Next slide, please. So midwives matter and Black Lives Matter. Here we have my lovely friend Anna Horn with that sign when there was a rally just recently about the shortage of midwives. So we have to address both issues, and this is part of an ongoing humanisation of birth, that these things have to be forefront in our minds. Next slide, please. So the humanisation of childbirth is around connected, trauma-informed care, paying particular attention to those who need our services more, to those who maybe don't reach out, who don't come to us when they've got a problem, but really kind of understanding the importance of relationships, of this connection between midwife, between healthcare professional and the mother. So whatever type of birth the woman has, that she feels that she's absolutely centred to that care and that she is respected in every sense of the word. So building cocoons around her, making sure that her and her family are respected, whatever cultural background they're from, and listening to them and finding out what they want, what they expect, and introducing the evidence in a way that they understand. Next slide, please. So when we do that, we find that we get words that come up like this, which actually should help to address any kind of disparity. So when we talk about love and advocacy and compassion and kindness and trust and respect and personalised care and relationships, if we can get that kind of focused on our care for women and families, then we will make a difference. And I know that we make a difference when these are the focuses of our care. Next slide, please. Love and connection is not just my kind of, this isn't about what I think, this is there's a whole evidence base behind the fact that if we can love those, we can love each other, love those we serve, and love those that we work with. And that's not about being in love, but it's about getting back to basics and understanding physiology and understanding how small acts of kindness, small connective approaches to care can actually make a huge difference. Next slide, please. So courage and compassion for me go together. They interact. They when we touch base with our compassionate selves, we're more likely to be courageous, to speak up for those who are in most need, and to be kind of be advocates. So the advocacy comes into play when we can be more compassionate. Next slide. Compassion, when we look what it is and what it does and the evidence behind it, it's not just about kindness and softness, and it's not a weakness, but this is the most important declaration of strength and courage known to humanity. It's difficult and powerful, and it's infectious and influential, and crucially, it's perhaps the only universally recognised language with the ability to change the world. So if we've got this universally recognised language, surely we can use this when we're trying to address racism and trying to improve outcomes for families from Black and brown backgrounds. Thank you. Next slide, please, Eugene. And here's a bit of the evidence to show that it actually does make a difference. Next slide, please. And we matter, you matter. So midwives matter, doctors matter, everyone that's listening today matters. And we have to understand that we all play a part in this. And this is particularly around maternity services. So I'm just going to give you now some little tips that I think might help along the way that we can use to make sure that we kind of address these issues that we're talking about today. Next slide, please. First of all is to, I'm going to come on to some literature around racial disparities, but this is for everyone to sustain your practice. So if you're midwives listening or doctors or healthcare assistants, and you feel burnt out at the moment, you feel overwhelmed with what's going on, and all these pressures are kind of laying down on you, then you have to look after yourself. So your individual well-being is really important. So that love that we talked about earlier is about you as well. So respecting yourself, because if you don't do that, then you're not going to be able to give out to everybody else. So looking after yourself is crucial. And Jan Smith's book, Nurturing Maternity Staff, addresses some of the issues around racial disparities, as well as looked at so opening your heart to all that needs doing, but also making sure that you take these 90 seconds, 5 minutes or 30 minutes to really care for yourself. Next slide, Eugene. And because the solution isn't just about self-care, it's also about caring for each other. Next slide. Lifting each other up, making sure that we're all seen. So reaching in, caring for each other, making sure that we are okay. So if you see one of your colleagues and you feel that they're not doing that well at the moment, ask them how they are, but really connect. Don't just say it in passing, give eye contact, giving touch, just sometimes a hug is needed, but reaching out to those that really are in need can help us to shift cultures. It really helps to turn things around, and it helps us to feel valued. And it gives back to us. So every time we do something like that, next slide, please, Eugene. Every time we do an act of kindness, which can be as tiny as a touch, can actually have a massive impact, and it ripples out right across organisations. Next slide, please. Acting and commending and teaching is something that I learned about later in my career, and I wished I'd have known about it earlier. So this is about lifting each other. So if you see something that is really making a difference, so you see a midwife or a doctor that's really helping someone that does need that extra care, then acknowledge it, then commend them to other people, then ask them to teach how to do that. So I've got loads of examples in practice of how that's really not only changed the way a shift is going when you're working, but also a departmental kind of culture. And then hopefully if it continues, then and you start to talk about it and share and publish what you're doing, then it can help the organisation as well. So this is about connection, relationships, and making a difference. Compassionate leadership. Sorry, my telephone is just ringing. So when we do this, what happens is we do start to feel connected. Yes, next slide, please. We can start to feel more connected to what we're doing in practice, and then we can share that same love and affection, whether it's eye contact or touch, or whether it's the way we speak, the language we use, to those we serve. It's kind of like goes across. It's like osmosis, that when we speak in appropriate ways, then it changes the way we care. I was ill last April, really seriously ill in hospital. And one of the things that I was in for 3 weeks, and it was a very, very busy ward. And the nurses that made me feel better were the ones who connected with me, not necessarily hugging me like this, but, giving me that eye contact, lowering themselves to my level and really giving me that special attention that I needed. And actually it saved time because I wasn't always on my call bell then trying to get somebody in. So just those moments whilst you're doing something, you might be taking a blood pressure or doing any vital signs, but that eye contact, that smile, that love that passes across from you to those you're serving really does make a difference. So imagine the impact that we would have if we could do that every day, if we could practice it and do it every day. Next slide, please, Eugene. I'm sorry if I keep saying next slide. Look at the impact here that you can see that one student midwife has had on a person, on a birthing person, a woman who's actually felt traumatized. And before she wrote about this, she was talking about her trauma. But, you know, just the hand holding and asking, connecting with someone can really make a difference. So that's a student midwife doing that and, you know, transforming a birth experience. Next slide, please. So courage and compassion isn't an easy way out. You know, it's not easy to kind of think about these two things consistently. Next slide. We have to do the work. We have to learn, and then we have to learn more. And we're on a journey. I'm still on that journey of learning more and understanding. And this morning, listening to Zara, I've learned again, and I've kind of, you know, it kind of goes deeper and deeper, and reflecting on, you know, like she talked about the BAME word. And so we have to keep adapting our language and listening to the communities that we're serving. But learning and learning and learning is really important, and we have to take responsibility for our own education. Next slide. So at All for Maternity, where Anna, my daughter Anna, who's a midwife, we've really taken a kind of a proactive approach to this. So everything we do is about representation, is about opening our minds, about sharing the issues that are happening, but also sharing the solutions if we can, and about anybody that contributes, really recognizing that they need to be thanked, they need to be paid, they need to be valued in every sense of the word. So if we're asking, say, for example, a South Asian midwife to come and help us, then she will be honoured and paid and valued, and we listen very carefully to all those issues. Next slide. And you'll see from the next slide that, you know, all our journals now have representation, and this has been happening for the past 2 years. That we've, you know, it's not just about, and it's not tokenism, you know, it kind of goes right through. So when we take on more staff, we look for midwives and support workers who are from those communities that are marginalised, and, you know, we honour them and ask them to be part of our team, and we feel so grateful that we can do that. Next slide. We have open access e-learn modules that were created by those communities, and they're there for everyone to access, hopefully addressing some of the issues around culture, race and bias in maternity care. Next slide. So we have to examine our own position, our own biases, and it's not easy, because sometimes, you know, I've got biases that I'm shocked at sometimes when I recognise those biases, but it constantly reflecting and finding out what they are, and then realising that some of the words we use aren't appropriate. And sometimes it's others that tell us, or, you know, if someone tells me, Sheena, that's not quite right what you've just said, then, you know, being grateful for that, the way we respond to it is really important, because, you know, we all have to keep learning. Next slide. Listening, communication, listen, keep listening. And if we can act on what we hear, well, we should always act, but act appropriately. Next slide, please. We have to have courageous conversations. How many times are we in a situation where we hear a racist comment? And it might be, many times it's completely, it's unconscious that somebody will say something. This happens in my family, as well as in my friend group, as well as when I'm working. So these courageous conversations are absolutely crucial. Next slide, please. Here are a few tips, and you can use these tips right across the board with anything that you hear that isn't appropriate. So you can be an advocate in many senses of the word using these kind of things. Did you really mean to say that? And then if you're the person that they're talking about, that's not how I see myself. Can you explain what you mean exactly? I must have misunderstood. Can you rephrase that? And then ask people if they're okay. Anyone that's talking in this negative way, ask them if they're okay and if you can do anything to help them. And then maybe set a meeting up, agree an agenda and take food. You know, attacking people who say the wrong things. I've been attacked many times because I've said the wrong thing. Isn't the way that we can work to try and change things. We have to work together compassionately, respectfully, calling out when need be, but do it in a way that's, you know, so that people can learn and flourish rather than get sort of defensive, and then it doesn't help anybody. Next slide, please. Don't fit in with negative culture. If you hear anybody talking negatively, it's up to you to speak up about that. You have to do that, and using those phrases that I've just given. It's easy sometimes to slip in, but don't. We have to acknowledge when things aren't right. Next slide. We're all responsible for the culture of our workplace, every interaction we have every day. Don't just rely on leaders. Leaders are very important, and leaders can model the way, but we have to be the ones that make the change, and it's up to every individual. Next slide. I've nearly finished now. So find your tribe to help you, to support you, but be inclusive. Everyone should be welcome. So make sure that you do reach out to those who sometimes may not feel that they belong, and tell them that they do belong, and help them to lead that group. So lift them up, give them the, you know, it sounds patronising saying give opportunities, but you can do that in a way that's not patronising. So the language you use and the support you give has to be non-directive, non-patronising, but just be welcoming and loving, and then you'll see that people will come. Next slide. Relationships matter, and if we focus on safety, not risk, and on relationship-based care, not system-based care, we'd make maternity care safer for everyone. Next slide. Thank you so much for listening, and I hope there's been some little tips there. So now I'm just open to questions. So please ask me anything you want. Thank you for listening. I'm sorry, I'm sorry I had to keep saying next slide, please. It's really monotonous, isn't it? And I just feel a bit conscious of that. So sorry about that.
Sheena, that was fantastic. Thank you so much. I'm conscious of time, but we have got 5 minutes. If anybody wants to ask a question, I'll just wait to see if any hands come up, Sheena. I think there was lots and lots of chat. You might not have noticed.
No, I didn't.
You were going on, Sheena, but one of the real key things that came out of the chat, and it really resonated with me, was around the importance of touch. And how we've lost some of that. And actually we'll have lost some of that through COVID as well, because we've had to keep distanced from people, we've had to have face masks on, we've had barriers to actually communicating and being involved. And I just wonder what your thinking was around that, because that clearly came through to me in the chat. There were lots of people liking those comments.
Okay, yes, I can say something about that. I was in hospital for 3 weeks during COVID. I didn't have any visitors, and I felt the touch through gloves, and I felt the touch. So nurses were touching me when they were doing examinations of me. They were touching me. Doctors were touching me, and the way they did that was different. If they had a connection with me, it was different. I had one nurse who never asked me how I was in the whole 5 nights she worked. And yet others would lower themselves to me and touch me because they were going to touch me anyway. So we have to get round this kind of like fear of touch. And sometimes you can touch people with your eyes. It's the eye contact as well. So it's not just about physical touch. It's also about emotional touch, the way you position yourself. Somebody's got their sound on.
I've just changed it. Keep going, Sheena.
And then the other thing is, now with our colleagues, you know, making a cup of tea for someone you might not be touching. I mean, I think we'll slowly be coming around from being able to hug again, you know, and I did show a lot of images of hugging, of course. And it's just because I think that demonstrates that, you know, if we've got masks on and gowns on, sometimes, you know, maybe just we are touching our colleagues anyway from time to time. We're in close contact with them. So making a cup of tea, knocking on a door, are you okay? And I know everybody's flat out. I'm hearing about it all the time and seeing it. So I know everybody is, but honestly, those small things can absolutely make a difference.
Sheena, I'm just going to bring Melissa Brown in because her hand's up. Melissa?
Hi, Melissa.
Hello, good morning, Sheena. Lovely to listen to you as always. So I just wanted to quickly touch on, you know, what you were talking about with obviously the compassionate care and model, I guess, for staff and colleagues. And I mean, I recognise that all it takes is it can take, you know, one person within a unit to help to shift a culture and foster that that kind of that compassion. But I guess my question is about whether you've got any ideas about how we can implement that at a structural level, you know, whether, you know, what changes need to be made in the broader context of maternity in order to foster that compassion, that kindness, so that it filters down to the individuals, the staff on the ground, and then to the women, you know.
Yeah, really important question. Thank you, Melissa. I love what you've asked me because it's one of the topics I'm really interested in, and I'm writing a chapter for a book at the moment on compassionate leadership. And if you've never heard of Michael West, who works for the King's Fund, he's written, there's loads of TED Talks, there's loads of YouTube clips that he talks about this. And you know, kind of in Jan's book as well, there's a whole chapter on it, how leaders need to foster this type of leadership. And you know, it kind of is the only answer, because it's like back to basics. If we want to, we need more midwives, we need more staff, we need the NHS to kind of have more resources, we know that, but the ones who are working at the moment need looking after. So right from the top right to, you know, the cleaner or anyone who's working needs that kind of approach. But very often we don't have that, you know, in the organisation. It hasn't happened yet, but what we have to do is keep talking about it. And I know it feels tiresome sometimes, like we feel like we're I feel like I'm constantly talking about these things. But if it just shifts one person, if just one leader hears this and thinks, I'm going to look into that. Michael West written an amazing book called Compassionate Leadership, and I'm working through it at the moment. And there's solutions in there for organisations. There's ways to, you know, kind of to work through ways of kind of doing practicing more compassionate leadership, and it does take practice. So some people it's easier than others, you know, some people are naturally aligned to that kind of leadership. And the other thing I just want to say is that Anna and I, my daughter and I, we're very fortunate that we've been given the opportunity to work for the NHS England at the moment on a programme that is nurturing and supporting the well-being of midwifery leaders. And it's a pilot at the moment, and compassionate leadership is integral to that programme. And we've got 50 midwifery leaders on it at the moment. And if it's successfully evaluated, it will be hopefully rolled out to everybody in the country. And so this is, you know, we just have to keep raising awareness of it. And so your question is absolutely fantastic, Melissa. And I'd love to connect with you again about that. So if you need any help, just get a hold of me.
I definitely will. Thank you, Sheena.
Sheena, thank you ever so much. I'm conscious of time, so I'm going to draw it to a close, but just noting that on Menti, the absolute $6 million question around the impact of continuity of carer, and actually the other side of that, of the numbers of midwives leaving the profession. And it feels like the first bit we've got to address is actually retaining and recruiting midwives, and we've got to look after them, and we've got to reshape this career.
Absolutely. And so I'd love to talk more about that, but we haven't got time.
So thank you, Sheena. There's a couple of things. One, I've seen some requests for making sure we share links. We will share everything with you that we are sharing with you this morning. We'll make sure you've got access to all of those. And also Eugene has just put in, there's going to be some questions. So we're going to draw to a close for a break, so you can all grab a cup of tea or coffee. And also, yeah, Sheena, of course.
Before I go, I have to go to a meeting. Can I just quickly say, if anyone wants to get a hold of me to speak further about anything, I'm on social media, Instagram, Twitter and Facebook, and I have a website as well. So thank you, everybody.
Thank you, Sheena.
Thank you.
So we'll have a break now. There'll be some questions on Menti for you to complete, if you can do that. And we will come back at 10:30, Abby, I think it is. We reconvene for the next speaker. So grab a cup of tea, and thank you so far for keeping with us on this journey. Ruth, I'll just give everybody another minute and then we'll get started if that's all right. Okay, welcome back everybody. I hope everybody managed to get a drink. Really thought-provoking first part of the event. The more I listen, the more I learn, the more I realise there's a lot that I don't know, and I think that's really important. We don't know what we don't know, do we, until we start to listen to others. So really helpful for me this morning in shaping some of the thinking and some of the work that we need to do across Bradford district and place. So we're going to move on. I'm going to hand back over to Abby to do some intros. Abby?
Hello, welcome back everybody. I hope you're all refreshed after a little break. Our next speakers are some homegrown speakers. We've got Polly Masson and Ruth Shaw from the Reducing Inequalities in Communities programme, which is a movement of people and projects who are working together to reduce health inequalities and close the gap in central Bradford so that everyone can live healthier, happier and longer lives. Welcome to Polly and Ruth.
Thank you, Abby. Eugene, are you able to share our slides? Is Eugene back? Oh, perfect. That's very kind. Thanks a lot, Eugene. I don't use Teams very often, so I'm not the most confident in sharing screens. So my name is Polly Masson and I'm the lead for the Reducing Inequalities in Communities programme. And I'll let my colleague Ruth introduce herself when we do our handover in a moment. So next slide, please, Eugene. So for those of you on the call that are not familiar with the Reducing Inequalities in Communities programme, I'm going to start calling it RIC now. It's a programme we developed within the Bradford area a couple of years ago. It came about just as the 3 CCGs were transitioning to become one, and it was a result of NHS England reducing its allocations to CCGs, recognising that we need to make a greater impact on reducing inequalities. So when this increased allocation was made for our local area and for the Bradford, what was the Bradford City CCG, our clinical board were really committed to actually making a difference to reducing inequalities. They wanted to make sure this increased spend would truly make a difference for the population it served. So it decided to use this funding to create the RIC programme. And as Abby said, this programme is a range of projects that we hope will make a real difference to health inequalities in our population. We're lucky that we have a range of partners involved who are involved both in designing the work and actually delivering the projects. There are over 50 groups and organisations in Bradford Central area working on this at the moment. The key feature of this programme, it's really a test bed of intervention. So it's taken a load of ideas of things that we think will work within our system and to test them in the central Bradford area. But the idea is that if these projects and interventions work and we are able to get the evidence to prove that they do, then we can present these back to our local system partners and take the business case for spreading them across our local place. Next slide, please, Eugene. So as we've said, the RIC programme is built up of a range of 21 projects and we started going live just as COVID hit, so that has impacted us a little bit. But despite that, we have got all 21 of the projects you'll see on this chart now live and delivering in our local place. And you'll see those 21 projects cover the range of life stages. And this was a really important thing for us in the Reducing Inequalities in Communities programme, because yes, we want to reduce health inequalities, and to do that, obviously, you need to focus on preconception and children's services. But we're also very aware of the fact that we've got a big population in our area that live with health inequalities today. So some of our projects also look to mitigate existing health inequalities. You'll see, for those of you that work in our local place, that some of these projects here are a mixture of completely new ideas. So, for example, young people social prescribing is a new thing for our place, but some of our projects are also building on previous good practice and pilots. So, for example, the doula project, which you'll hear about in a moment, is an example of one that we've expanded through the RIC programme. Next slide, please, Eugene. So obviously birth was a critical life stage for us when we were developing the programme. So we want to make sure that the work that we do within the RIC programme helps to contribute to Bradford babies having the best start in life. And so we've actually got 4 projects within our birth stage of the RIC programme to focus on this area. And the idea is to target those vulnerable groups within the RIC area. So for those of you that don't know Central Bradford is one of the most deprived areas in England. So the majority of our population are classified as being in the most deprived area. And we also have a very diverse population. And I'm very conscious of what Zara was saying earlier. And we're also navigating that. How do you move away from the BAME label, because it's not the best label to be using? So you'll sort of see oblique references to that, but we're currently thinking about how you describe this as we go forward. Next slide, please, Eugene. So in terms of trying to work out how to best focus our energies within the RIC programme, we developed a logic model which helped us sort of understand what are the issues for each of the life stages that we have in our communities. And some of you may be familiar that the fact that the RIC area has a really young population. It's one of the youngest in the UK, but it also has a very high birth rate. And as some of the factors that Zara mentioned upon in our project, the risk factors for around this are the same for Bradford. We've got high infant mortality and child mortality. So when developing our sort of short list of projects to include in RIC, we wanted to make sure that we built on, and that's sorry about the typo, built on existing insight and experience. We weren't starting from a blank sheet within Bradford. We were lucky that we had a really strong children and maternity programme that was led by Ruth, and they'd been doing lots of innovative work as they went through the year. So we've been building on that in our design. We also were keen to make sure that the RIC programme had a really strong evidence base in terms of defining what we wanted to do, but then also evidence the impact we were having. So we've actually built into the programme a small element of research capacity called the Bradford Inequalities Research Unit, of which Josie, who's going to be speaking later, will fill you in more detail. But having a group of research people aligned to our thinking, not only were they were able to scan the evidence for us and give us an idea of what works of local data. We had a newly emerging population health and wellbeing team at this point in time, so using the insight from both these groups is really important. So the Inequalities Research Unit did a bit of a deep dive for us as we were kicking off the RIC projects, and some of these are some of the highlights they flagged in the maternity element. And I just wanted to point them out here because I think that's really important about how we use data and how we make sure we dive down deeply where we need to. And I think the Black and minority ethnic population data is really important, because if you were to look at Bradford and Craven as a place, we've got quite an even spread of different groups of population. But if you focus on the central Bradford area only, 85% of births in that period, 16-17, were to mothers from Black and minority ethnic populations. And I'm sort of smiling because we always think of our non-white British, our white British population as the majority. In Bradford, that's not the case. Our South Asian community is the majority population. So in planning and designing services, we need to be mindful that actually we sometimes need to look at smaller groups of people when planning our service to understand who is accessing them and who do they need to meet the needs of. So to break that figure down, when this report was written, 63.8% of Pakistani heritage were our biggest group for mums. Then we have the other white, which is quite a big pot in itself, and then white British. So again, it's really important we think about this when planning our services, because even the Asian community is not one big group themselves. There are subgroups within that. The other interesting, well, wasn't the only other interesting, but another interesting point when we speak about smoking, we make a sort of sweeping generalization that Asian ladies are less likely to smoke, and I guess that is true. However, in the data that the research unit presented to us said, okay, the Pakistani heritage women might not be smoking themselves, but they are quite likely to be living in a smoking household. So we need to consider how this might impact on our services. So I think the point making here is just actually thinking about the data and being able to interrogate it to understand what we need to do to adapt our services to meet our population's need is really important. I think we've learned a lot through COVID in that one service does not always fit all, so we need to be very clear on what are the needs of our community and what inequalities we're trying to address. So I'm going to hand over to my colleague Ruth now, who's going to go through the 4 RIC projects in detail. I'm going to put a link into the chat now just about for the RIC website, because that'll provide a lot more information about the RIC programme in general for those of you that are interested. Over to you, Ruth.
Hi everybody, so I'll start by introducing myself. So I'm Ruth Shaw. I was previously Ruth Hayward, and I'm still getting people who say, oh, that's who you are. Even though it was 2 years since I changed my name, but I think since COVID we've not been out and about met people, so still let people know. My job title is, I have to look at this, Senior Head of Integration and Change, in brackets, Health and Care, with women and children tagged on the end. In old-fashioned money, I'm the sort of maternity and children's commissioner within the clinical commissioning group. So quite a broad remit, but I've been sort of working around the area of maternity and children, and they interlink so much for a long time. And the other thing is I just want to give a word of thanks to Kirsten, who's on the call, who pulled together sort of my end of the slide set. It's very wordy because she knew I needed the help. And it hasn't got all the pretty pictures that other people have got for that very reason. So that's because Kirsten knew I would need the prompts along the way. So next slide, please, Eugene. So we have a series of projects, and what I've been sort of thinking and reflecting as we've talked as I've listened to the presentations this morning. And I think a lot of what we do is build on what's already here in Bradford, or sometimes start again. And there is something about how do we stop this stop-start approach and actually build some longevity into some of our programmes and make sure things are embedded. And I think that may be a reflection of me being around for a long time as well. I see things come around in cycles, but I think there is more we can do to embed things. So the Advanced Midwifery Support programme that's being delivered in partnership between Better Start Bradford and Bradford Teaching Hospital. It's around improving pregnancy and birth outcomes for women. It looks at infant mortality, the need to reduce our numbers, the need to, get safer birth rates, improve maternal mental health, and increase breastfeeding rates, all the things you would expect to be there. But a lot of the work is about reaching out to women in communities. So obviously this is located in the Better Start Bradford area, again, very locality based. And even with this, it's a locality within a locality because of the some of the complexity attached with how we could reach the whole of the Better Start Bradford area. So it is a locality within a locality within Bradford. So it's not reaching as many people as we probably would like to do. So that's something to think about. And it's about making us changing how we approach, how we access women who aren't able to engage with services easily themselves. So it is that change of approach. Next slide, please, Eugene. Thank you. So the piece of work, the research that's happening now, because it is all research, because it is all part of the Better Start Bradford sort of 10-year programme, which is a research programme. So at the end of this, we will know about whether the implementation and delivery has worked, and that's really helpful for me with my commissioning hat on, of them making the case for change and for the case for expansion. So it does link together, but it is very helpful. And we focused on service design, building on the previous work in Better Start Bradford. So they had developed a personalised midwifery approach, which was developed at the beginning of the talk about continuity of care under the Maternity Matters guidance that came out many years ago now, but it very much focused on the sort of postnatal and prenatal and postnatal elements, and we didn't include the intrapartum element. So this is a change that we asked Better Start Bradford to make, was to actually make this a much more of a rounded project. So the key project outcome is about successful continuity of carer relationships, and the expectation that this would lead to improved outcomes and increased engagement from families with midwifery and maternity services. It also, as I've sort of alluded to, gives us some insight and guidance for the practical implementation of the midwifery continuity of carer model, which we need to deliver at scale. And there are, you know, emerging issues around that whole programme of work, but we continue to go through in our Better Start Bradford work to see what we can deliver there. Can we have the next slide, please, Eugene? So successes and challenges, and they have been a mixture, I think, here. So we managed to, you know, it was quite an attractive role, so we managed to recruit these midwifery support workers who were trained to work with the midwives, and we've managed to enhance the support offer. So women were offered extended appointments to give access to parental education and public health messaging, because that was key as well. How do we link all the other things that are happening in the district round, you know, smoking cessation, the importance of diet, that kind of thing. So we link, it does all link together. And we extended the offer of support past the standard postnatal period as well. As you can imagine, there have been challenges. The midwifery recruitment issues have impacted on us. We had a plan for a second team that hasn't been forthcoming as yet. And COVID hasn't helped with that as well, because there have been pulls on staff to go back and support the mainstream service delivery. And this is another thing that we need. I've been reflecting on that, listening to people talk, is how do we make sure we don't lose those very important elements which are around increasing the access of some of our most vulnerable population, because we need to refocus onto this sort of core business of a service. How do we make this the core business? So I think there is something we need to think about here. We're just in the period of, we've just gone from sort of implementation to delivery around this part of the project. So we're waiting for our first quarterly out report since mobilisation. And there are some things that are emerging from that. It's where you've got small numbers, how do you record it? How do you share the evidence? That kind of thing. But we will work through that. Next slide, please. Stopping smoking in pregnancy. Again, this is a project that it was proposed by the public health team in the council and delivered through the Bradford Teaching Hospitals team. A bit obvious really, the aim is to enhance smoking cessation support for pregnant women with a community focus on the wards with the highest smoking prevalence. We know that smoking cessation is one of those things we've looked at time and time again. It's something where everybody knows we should do better. Everybody would like to do better, but we don't seem to get the traction to keep that work going. I think that's my observation. We're using sort of the VCS to do work within communities to understand their reasons for why they don't engage appropriately with our stop smoking services. You know, again, it's about a system change. It's not about making the women change their approaches. It's actually how do we make the changes services change to make them more accessible. But also there's some cultural things here as well, and we shouldn't make assumptions about certain cohorts of the population don't smoke, because actually within every population there'll be an element that do, and we need to make the services accessible to them too. So it's about how do we do that, and also work with other colleagues around smoke-free homes messaging from pregnant women as well, because that, as we touched on, Polly touched on, you know, some of the women may not smoke themselves, but if you're sitting in a room full of other members of the family who are smoking, there's an impact there. Next slide, please, Eugene. So, thank you. Midwifery support workers, again, have been recruited and have taken their practitioner training. And we're working to develop that alongside with the city community midwives to make sure that the voucher scheme is embedded within the service delivery. The training needs assessment around the use of CO monitors and smoking cessation in community midwives. We've historically done a lot of work about making sure that all midwives have access to a CO monitor. And I think, again, it's a reflection. You do a piece of work at a point in time, but actually, how do we embed that so that continues to be relevant and is having an impact, 2 years later, 5 years later? Because I think we take our eye off the ball because the next thing comes along, and this isn't a criticism of anybody, it's a reflection of the amount of work that we pile on people and expect them to continue, take on something new, but nothing goes off the end. It's really complex for people. And again, we're working on the data collection, monitoring and evaluation so that we can share our learning across the system. Next slide, please. So the doula service, something close to my heart. I was involved in the initial sort of setup of the Bradford doula service when the Bradford City CCG were the first people to commission them and develop them. And they've been expanded through RIC funding and through Better Start Bradford funding. So again, it's a lot of focus, but the focus is in one community area, one locality, because of the way that the Better Start Bradford localities overlap with the Bradford City areas. So we're putting a lot of intervention into a small locality, but I am confident that there will be the women who need that support sitting in inner city Keighley, other parts of Bradford that are in the old Bradford district CCG area. And so my sort of thinking as I'm listening in the event is we really need to think about how we reach and expand what we're doing. So the service is about providing practical and emotional, and I'm very clear it's non-clinical support to pregnant women from 6 weeks before birth, during labour and 6 weeks after birth. It's a flexible model, so support can be delivered within the home, within the community, or in any location where the woman feels comfortable. We use accredited volunteer doulas, so doulas accompany the women to partners, to appointments. Like that's a different service altogether. We build positive relationships across statutory and non-statutory services. So that wasn't without challenge. I think when the doulas started going into hospital settings, there was a lot of work to establish the ground rules about what doulas do and what they don't do. And also when they're supporting women in home and the midwife might be appearing in the home. Again, it's about that clarity that a doula is there to support the woman. It's not a clinical role. It's about support, practical support for women who may not have any other a partner or a family member or anybody else who the rest of us might rely on through sort of pregnancy and birth. And they have a role about ensuring women can make informed choices about the care, because we know that, if you are not able to speak the language that the midwife is communicating to you with, or if you have a lack of understanding of some of the technical terms that are being used, you're less likely to make that informed choice. So their role is around that. Next slide, please, Eugene. So referrals could be made by any services working with pregnant women and families. Referrals are open not only to health sort of organisations, but to social care, early years, community organisations. So it is an open sort of referral system. And I think the easiest way to explain this is hopefully we're going to show you a quick video from the doula service. I think that relies on clicking the link. Is that right, Kirsten?
There's no sound, Eugene.
Can you not hear it?
No.
It might be because I'm actually. Hold on 1 second. Sorry about this.
Don't worry. It's probably us trying to be too technical. When I certainly am not technical, so I can't offer any support.
Can you hear it?
No.
No. I think it's because it's a video, so with it being a video, sharing the video, the sound isn't coming. I can try and put on the captions. Did they do captions? Yeah, is that okay? I'll try and put on the captions. So I'm sorry about this, guys.
What we can do is share the video with anybody who wants it after the event, if that's helpful.
Yeah, I think we'll have to do that. I'll put in a link to the video now. In the chat. Yeah, I think because it's a video and I'm sharing it, you're not going to be able to hear it. Shall I move on with the presentation? Sorry about that, Ruth. Yeah.
Oh, somebody's giving you guidance.
Okay.
In the chat.
Let's have a look. On the bottom to share icon, friend icon. Click on it.
Some audio.
Ah. Thank you.
Give that a try, and then if that doesn't work, we'll move on. And if that's all right, Amanda.
Of course it is, Ruth. I think it should work, Eugene, actually.
Pause again. Share confirm. Click on.
It's include computer sound. When you click share screen,
Yeah.
on the top right, include computer sound, you just need to press that button.
Got it.
We have the
that's it.
Perfect. Thank you, guys. Teamwork.
We have two strands to the service. We have the training strand, and then we have the service itself, where we support 6 weeks in the latter stages of antenatal, building up towards birth. We support during labour and childbirth as well, and then we go on to support 6 weeks postnatally. We work really closely with maternity services, with voluntary sector statutory organisations across the city, in order for them to kind of recognise perhaps the women they're supporting, the families that they're already working with. Perhaps they need that additional hand-holding support during pregnancy.
Evidence shows that having support from a doula improves outcomes for both the mother and the baby. So this project means that the women who need it most, often the most vulnerable women in society, have access to this service.
I am originally from Pakistan, so I moved to England 10 years ago, and I had no social or any emotional support when I was having my own babies. I was not aware of this amazing, wonderful project, because it brings huge, I just get goosebumps by talking about it. I'm very emotional, I'm sorry, but it brings so huge difference to a woman to have a memorable experience of giving birth, to be mentally and emotionally stable and confident, to know that what she's doing is right. When you're in a vulnerable state where you're giving birth, all you need is a positive atmosphere, All you need is encouragement.
We take women to the antenatal appointments. We help them make decisions about where they want to give birth, how they want to give birth, including what pain relief they might want, including the positions of birth that they might want to be in. We would actually go to the hospital, and we would be with them throughout labour and throughout their birth. And again, it's just that thing of having that support there, you know, making sure the birth plan is being followed.
It was a partner that was a lot more vocal this time around, and he said, I was so worried about how I am going to cope and help my wife and my family, and I felt it was all on my shoulders. And he said, working with you and the locality officer just made it all so easy, and I felt like the support came at the right time when I needed it.
When we provide support to the women, we are actually providing support to the whole family, which is to have a better mental health, a better strong bond is built between mum and baby.
This pandemic has changed the way we provide our doula service. However, the women have still reaped the benefits.
I did a doorstep visit, and I just think pregnancy is a really alienating time for some ladies without a pandemic. So I just think, especially now during the pandemic, we can do Zoom. We're a friendly face, we're accessible, we give them ideas. You don't have to be there to hold someone's hand. You can do it by Zoom. You can do it on the doorstep of someone's house. And I saw the benefits of that. And the lady actually said, I feel so much better already. She said, I feel like a little rainbow's been brought to my door today. And that just made me feel there is a point, even though we can't go into someone's house, the doorstep visit is purposeful.
Even if we think that we might not be doing enough at some points, like in the pandemic, for example, our support is invaluable to these women, and they're fully, you can't put into words how much they appreciate it.
When I heard of this project, I said, that's it, that's what women need. We need to make birthing experience a memorable one, more confident.
I have seen firsthand the difference it makes to mums and their families, who can be very isolated and can be quite frustrated, especially with establishing breastfeeding. And it can help the whole family to have a better start with their child.
We are talking about providing this service to everybody and every woman. So it counts in all those who are comes under minority groups, all those women who have language barriers, all those women who have no access to other facilities, which generally we might all be having. So when we provide this.
Hi, sorry about that, Ruth. Are we able to continue? But I'm just time.
Yeah, I think there's only 40 seconds left, Eugene. So keep going, and then Ruth will just close if that's all right. Yeah, keep going, Eugene.
All those ethnicity, all those minorities groups, or Asian families or Black families, I feel that we are trying to make Bradford a better place to live for our future generation.
How do you follow that? So I get the warning about time, and maybe that should have been the end of our presentation. Just a couple of things that I just wanted to say. One is I've got to write a business case around extending doulas. I think I'll just make everybody sit in a room and watch that, and that should be it. The other thing is that what we haven't touched on here is around the impact of the doula service on the actual volunteers. Because one of the things that was seen as a criticism was the high turnover of volunteers at one point in the service. But what actually, when we unpicked it, it was because the volunteers were going on to further education. They were going on to train to be midwives. They were, there was a a knock-on effect, probably an unintended consequence of getting the volunteers who came from all walks of life, and actually so that was improving the sort of the educational ability of people who were living in that community, because the volunteers come from that community. So I think it's just something not to be lost on. Very quickly, our last project is around genetic risk on close relative marriage. This builds again on work that's previously happened in the system. So again, my point of let's not keep reinventing the wheel. Can we just not embed things that are happening in the system? And it's about making sure that families, that people have that opportunity for advice and awareness, understanding the genetic risk. It's not about saying you mustn't do that, and you know, if you do that, and this will result in a baby with congenital abnormality or anything like that. It's about giving people information and therefore informed choice around how they want to progress. Sort of, and options around screening and prevention and that kind of thing. I think we're on to sort of the last slide then, I think, Eugene. Again, we're working with regional experts and service users and developing training and health modules. So that genetic work, sorry, I've not done that justice at all, but the slides will be there and people can come back with queries and questions. We're very much in all of our maternity outcomes conversations at the start of a journey around how do we get the learning, how do we move that forward, embed it across the district. We need to increase engagement with services and to increase that engagement between services and service users. I think that's the point there. And improve awareness around recessive conditions and the genetic risks so that people, as I say, have informed choices, and reduce that impact of smoking on pregnant women and babies. And let's not just focus on the women, let's focus on the families. So I think that's the end of that. Thank you. So we're back to the questions then.
Thanks, Ruth. I'm going to just check because we're going to have to move to the next speaker, but let's just have a look what's come through Menti. So something around COVID impact on the quality of service delivered. So that came through in the video, Ruth, around those doorstep visits, I think, and Alia around how they managed that and still maintained contact.
Yeah, I mean, I don't work in maternity services, but I would suggest from what I hear that the answer would be yes. In that, you know, that loss of some of the direct contact, that loss of we've had issues around actual access to staffing, because what people sort of generally forget in the world is that the healthcare professionals got COVID too. So you know there have been lots of pressures on staffing and people trying to do their best to fill gaps, but we've not been able to deliver in our normal approaches. So yeah, I think the short term is yes, and we need to look at that and see what we can do to move forward.
Okay, thanks, Ruth. I'm going to move on. I'm just going to note, and it's fine, we don't need to go back, but there was another comment again about the exiting of midwives and the continuity of carer piece, and I just want to recognise with everybody that that is a theme, and I think there's lots of conversation going on around that. So Abby, let's hand over and move to our next speakers.
Thank you, Ruth and Polly. Just moving swiftly on then, I'd like to introduce Sandra Igwe and Melissa Brown from Birth Rates Inquiry. So evidence repeatedly shows that Black, Asian and mixed ethnicity women and birthing people are more likely to die, experience baby loss and become seriously unwell and have worse experiences of care during pregnancy and childbirth compared to those who are white. The inquiry brings the power of the human rights legal framework together with lived experience and maternity care expertise to investigate how systemic racism is impacting on maternity care, the harms being caused and what needs to change. Welcome to Sandra and Melissa. Thank you for joining us.
Good morning all. Really lovely to be here. It's been very, very interesting morning so far. So yeah, pleasure to be here and to present to you all. So I'll briefly introduce myself. So my name is Melissa Brown. I am the Participations Officer at Birthrights Charity. prior to being in this role, I was actually a registered midwife. I still am a registered midwife, but not working clinically at the moment. But I have been at Birthrights for the past year within this role, and yeah, so most of my current job is taken up with the running of this inquiry that we are doing into racial injustice in the maternity system. So that's a brief bit about me, but I'm going to hand over to my colleague Sandra, who's going to introduce herself, and I think probably set the scene very nicely for why I think most of us are here today, but particularly why we're doing the work that we're doing at Birthrights. So yeah, so without further ado, Sandra, I'll hand over to you to introduce yourself.
Yeah, thanks, Melissa. It's a pleasure to be here. Can you guys hear me quite clearly? Yeah.
I'm sorry, Sandra. I'm going to pop the presentation up for us, for everyone. Yeah. I think I can do that. So
I can introduce myself whilst you're putting the slides up, no problem. That's okay.
Can people see my screen at the moment?
No, it's a blank.
Okay.
Yeah, now I can see it.
Okay, let me just.
Yeah, so I'm Sandra E. Gray, and I'm the co-chair of the National Inquiry into Racial Injustice, and I'm also a trustee of Birthrights. And I'll explain more about myself once the first slide is up. Yeah, thank you. Thanks, Melissa.
No problem.
And sorry, I mentioned, yeah, so I'm the Birthrights trustee and also co-chair of the National Inquiry. But my entire journey started off from my personal lived experience. I'm just going to ask you guys just a few questions this morning. How would you feel if you felt that in your pregnancy, your labor, your birthing experience, you didn't have, dignity, didn't feel like you had autonomy or equality or choice of where you gave birth and how you would like to have given birth, or you just didn't feel like you had respectful care? In fact, you didn't believe that your basic human rights were met. And how would you feel if you were also more likely to have complications, 5 to 4 times more likely to have complications and die as a result of your pregnancy? 13% more likely to have postnatal depression and perhaps trauma linked to your pregnancy. You were more likely to report that you were not given pain relief. How would you feel if you believed you were not treated with kindness, with empathy, with basic respect? Some people here might feel sad. Some, like myself, would feel very angry, and that's probably the honest emotion that I had in my pregnancy. I felt really angry during my birthing experience because all of these basic human rights that I've just listed here, I didn't believe that they were met. In fact, when I asked for pain relief with my second daughter, I was refused and was told that there was a really long queue and I just didn't get any anymore. I really felt like my midwife at the time was being quite patronizing and quite mean to me and telling me that I'm exaggerating my pain. I didn't believe I had choice. And all of these emotions really made me question, was I treated this way because of the color of my skin, because of my race? And I actually said that whilst in pain and screaming. I said, are you treating me this way because I am Black? And I said that through the tears and the pain. Cut a very long story short, after this, I realized that my experience echoed so many other Black and women of color's experiences as well, and that led me originally to set up the Motherhood Group, which is a social enterprise that supports the Black maternal experience, and we do this through providing a safe space, should I say, for Black mothers and pregnant women to discuss all aspects of pregnancy, motherhood, but also to raise awareness of some of the issues that we go through that we don't believe services quite understand. And also through my advocacy work, I felt like joining Birthrights was the next practical thing to do, to not just have these conversations, these really important conversations amongst ourselves within the community, but work with those who are in a position to change policy and actually make a difference in our lives, so that my kids, my daughters, don't have to go through what I went through. And so because of that, now we've launched the inquiry into racial injustice, and I mentioned I am co-chair for it. And hearing some of the stories behind the statistics, it does make me quite angry, but I'm also not surprised. There is a massive wealth of information out there already that shows that there are racial inequalities in maternity care and in maternal mental health care as well, and our outcomes. But some of the themes that which I'm sure Melissa will go through later on, you know, some of the themes explored from all the different birthing people and women that have shared their own stories, not only echoes mine, but kind of reconfirms that there is a lot of work to do in this space, and not just, you know, work that we can, you know, more reports and more talking, but actual real action and actual implementation of what we already know exists. And that takes a lot of internal work to do. And so just to also add that 2 days ago, I announced the launch of my new book called Motherhood. And basically what that does is speaks about lots of the stories in this inquiry, but also my lived experience, and also the mothers that I've spoken to through the motherhood group, which does, you know, speak about talks or touches on some of the cultural barriers that kind of prohibit Black women from my community in accessing care, but also gives practical tips on how services and those who work in this space can understand how to, you know, speak and engage with women from our community, and also how to rebuild that trust, because I believe there's a lack of trust that we've built. If you hear these stories over and over again, what you will then do is say, okay, I don't trust that services or healthcare practitioners have my best interest at heart. And I don't really believe that's necessarily true, but that's what I've gauged. That's enough about me. I'm sure Melissa now can go into, you know, the nitty-gritties of the inquiry. Thank you guys for listening.
Thank you so much, Sandra, for sharing your story. And yeah, I think it's really important because it just puts in context, you know, as I said, why we're here and why we partly, you know, why we chose to undertake this work at Birthrights. But yeah, as I said, why we're all here today. So thank you. So, and yeah, just to give a bit of background about who we are at Birthrights. As I'm sure that there's some of you who are here today that might not know who we are and what we do. So Birthrights is a human rights charity. It was founded in 2013 as the UK's only organisation that focuses on protecting and promoting human rights in childbirth. So we do this in a number of ways. So firstly, through our advice line service, and also through our resources. Last year, we supported over 1,000 people through our advice line service. That's individuals and professionals. And our other resources, such as fact sheets, are available in multiple languages online on our website. We also offer training to healthcare professionals and other birth workers. So that's via NHS trusts and conferences. Last year, we reached over 4,000 people in various speaking engagements and training sessions. And we also undertake research and campaign to shine a spotlight on women who are most at risk of human rights violations in childbirth. So, for example, Black and brown women, and our campaign has taken the shape of an inquiry in this circumstance. So, so when we are thinking about human rights in the maternity care context, we are mainly focused on these elements of the Human Rights Act. So just to briefly run through it, I won't spend too long, but just as to give you a brief sort of whistle-stop tour through that. We are focused on Article 2, which is the right to life, and that is basically access to basic life-saving healthcare, which would include maternity care for mother and baby. Article 3, which is the right not to be subjected to inhuman or degrading treatment. So that shows up in the form of provision of care which prevents avoidable suffering. So, for example, timely pain relief, making sure that people have proper informed consent. And then we have Article 8, which is a right to private and family life. And that often shows up in the way that, you know, in women having the choice to choose their place of birth, so home birth or cesarean section, mode of delivery, and also their right to request or refuse interventions, so such as vaginal examinations, for example. And then we have Article 14, which is non-discrimination in protection and application of all rights. So that means that all women and birthing people have equal access to safe and appropriate maternity care, but also that it's delivered in a respectful way and a way that upholds a woman's dignity and autonomy. So why did Birthrights decide to launch an inquiry into racial injustice within the maternity system? So it's a big question, but essentially off the back of the 2018 Embrace report, which many people have referenced this morning, and we're all aware of it reported the shocking statistic that, you know, Black women are 5 times more likely to die in and around the period of them having their babies. So to us, it was clear to see that there were other issues at play here other than it being just explained by health risk factors and deprivation. So to put it explicitly, that systemic racism was having a part to play in these higher mortality and mortality rates amongst Black, brown and mixed ethnicity women. As others have touched on this morning, often the narrative is focused on Black and brown bodies being defective, being other, they're a risk to be managed. So as part of this inquiry, we heard from women, birthing people, healthcare professionals and lawyers, and they were all outlining the impact of structural, cultural and individual examples of racial bias and the deep and devastating impact that they can have on basic rights in childbirth, which then inevitably jeopardizes Black and brown women's safety, dignity, choice, autonomy and equality. So the inquiry was launched last year February, so yeah, just a year ago now. So we're coming to the end of it, but the inquiry was structured around a legal inquiry framework, and we brought together an expert panel consisting of people with lived experience and leadership, maternity care professionals, so that includes midwives, doctors, obstetricians, gynecologists, as well as doulas and other birth workers, human rights and healthcare lawyers, and experts from the anti-racism and race equality field. So we put, as part of the inquiry, again, we put out a call for broad and deep evidence from service users and healthcare professionals from across the UK. And the aim was to hear, as Sandra has touched on, the stories behind the statistics. So all of us here today know there's a wealth of data out there which backs up these, health inequalities and tells us that Black and brown women and birthing people are having worse experiences, worse outcomes. The evidence has been there, the same really for the last 20 to 30 years, although it's gained more, it's been highlighted more recently. It's been the same story for quite a long time now. So we were really keen to sort of lift the lid on that and hear the individual stories behind these statistics, what's going on a personal level, in an individual level for these women and birthing people, how do these statistics play out for them? So it's qualitative evidence that we've been gathering, and yeah, so, and then also we really wanted to have actions and solutions. You know, the focus was to make a difference and change. We, as Sandra, you know, spoke about, we've got all the evidence here. We know what's going on, and it's time now for us to make some action. So that was the main focus, really, of the inquiry. So this is our expert panel, and there's Shaheen Rahman, QC, who is the chair, and then we have Banish Nazmeen and lovely Sandra here, who are co-chairs. Okay, so as part of the inquiry process, the panel has met for 3 oral evidence sessions. So we met in June, July and September, with a focus on different themes at each oral evidence session. So in June, we heard from those with lived experience, where there was a focus on intersectionality, and we heard from migrant women. We invited Maternity Action, who are a group, a charity that support asylum-seeking, refugee and migrant women. And we discussed their experiences, in particular, the impact of the NHS charging system. We also had Black Beetle Health, which is an advocacy group who support LGBTQI people of colour, to hear from those birthing people and their specific experiences. In July, we looked at healthcare professionals' experiences and invited the NMC, RCM and the RCOG to look at how we can better support workers to combat racial injustice, as well as protect them from it. And in September, the session was focused on policy and systems change, and it was attended by NICE and Embrace. And we looked at structural and policy issues and how these can be changed and how existing ones can be utilised to combat racial injustice. So, oh, sorry, I've gone the wrong way. Yeah, no, there we go. So as part of our inquiry, we, as I said, we gathered evidence. So we put out a call for evidence, and we heard from over 300 people, those with both lived experience and professional experience. So we had 244 responses from our online written call for evidence, with 57 of those being from healthcare professionals. We held 11 focus groups targeting specific ethnic communities, and we also had one focus group with midwives. We undertook 14 individual interviews, including 3 with LGBTQ plus people of colour and 8 with clinical negligence solicitors and barristers. And we are also going to be conducting a UK-wide poll this month as our sort of final piece in the evidence gathering jigsaw. So that'll be being undertaken this month. So from across all those pools of evidence, from the online call for evidence and from the focus groups and interviews that we conducted, we were able to pick out 7 consistent themes, and those were safety. So that ranges from feeling unsafe. So when women and birthing people reported feeling unsafe when they went in to access their care, to feeling a threat of serious harm and death, and where poor, inappropriate care or negligence has led to actual physical or psychological harm. So we heard testimonies reporting that, and particularly from the clinical negligence lawyers and barristers, there were reports where there had been serious harm and even death. Then the second theme was dehumanisation, and so that pertains to a lack of dignity. Sorry?
Just a 2-minute warning. I know we've not given you enough time.
That's fine. I'm nearly finished. It's the last slide after this one, so thank you. So that the dehumanisation pertains to lack of dignity and respect, lack of empathy, and lack of curiosity. Then being ignored and disbelieved was a very strong theme that came through. So women reported, you know, when they raised concerns about themselves or their baby, they were often dismissed or minimised. You know, often there was a denial of pain, refusal to give pain relief, and people disbelieved when they were reporting they were in labour, for example. And another theme was consent, choice, and coercion. So lack of informed decision making or consent. Also not being offered options and being denied choices. Then the direct impact of race. So that's where so either stereotyping, microaggressions, right up to overt racism really has impacted on patient experience and their care. And then we saw a theme in the shape of structural barriers. So that's often translated into lack of interpreting services or NHS charging. And as I think was picked up on an earlier presentation, you know, where you know, this is a direct example of, you know, structural racism at play there for interpreting services in the NHS charging system. And then finally, we have workforce. So that was taken from our focus groups and interviews with healthcare professionals. So a lot of the things that were picked up with looking at representation or lack of representation in leadership, a culture of bullying and blame culture as well within the NHS. So we also captured experiences of COVID-19 and how that impacted directly on Black and brown women and birthing people, and also of positive care, because there were a few examples of positive care in there. And I think it was really important for us to highlight those because there are people out there delivering excellent care. And also for us moving forward, when we go to look at actions, and you know, it's really important to have those that positive care modelled there, so that we can use that and we know what it is that women see as positive, so we can emulate that going forward. And finally, just a quick chart there for you, just so that you can see how these themes you know, how they are showing how human rights are directly affected and potentially breached when women experience these themes. So how dehumanization relates to safety, which is Article 2, relates to dignity, which is Article 3. So it's just I won't dwell on it too much because I know we're running out of time, but it's just for everybody to see how these actually play into human rights and how it's impacting on women's basic rights, respecting care. So thank you very much for your time this morning, everybody. Hopefully you have some questions for us. We've got some questions and topics for discussion. I think some of them have probably been answered already this morning. I don't know if I misunderstood the brief slightly, but we gave you some questions, but yeah, if you have any questions for us, we're happy to answer.
Melissa, thank you for that. Sandra, it was just so hard hitting to hear you, and I was so sorry to hear that experience, because I think everybody on this call would not want women to experience that at a point in your life when it's supposed to be joyous. It's hard then to move on, isn't it, from that completely. So gosh, what a presentation. Melissa, Sandra, what a fantastic piece of work, and I think it gives us such an insight into the lived experience.
Thank you so much.
Let me just see if there see what's coming up on Menti, and I'll just see if there are any hands coming up as well, and people saying it was hard to listen to but needs to be shouted out. Absolutely, it does. So we go back to a theme a bit. Do you know if the midwifery training programme incorporates all elements required to ensure this evidence is embedded into practice? So that kind of takes us back to where we started with the conversation this morning, doesn't it? About how do we recruit people into this service and how do we embed what we're learning and what we know from the data into that. Did that come out in any of your interviews, particularly with the midwifery teams that you had the focus group and the interviews with, Melissa?
Yes, it absolutely did. Yeah, it's a real key strand running through it all, really. I think it really goes back to the training and making sure that when midwives come out of university and go into practice, they feel confident about delivering, you know, appropriate care for the women. And I think as I said, we had sessions with all evidence with NMC, and that was definitely something that was put to them with regards to the standards. And they are. I know they've said we'll be working with them in collaboration with them to make things. When, as part of the inquiry, we have some universal recommendations which will be coming out when the report is published, hopefully in May. And as part of that, there will definitely be some recommendations in terms of education standards. So I think it was a question that we had basically as a charity when we would sort of undertook this, about who decides what's on the curriculum, where do you know, who's the person. And I think there is some, from what I'm gathering, there is some uncertainty within the maternity world themselves as to whose responsibility it is to ensure that you know, that is on the curriculum, and it's a standard across curriculums, rather than just you know, you might get a particularly progressive university or forward-thinking university that decides to put you know, something on the syllabus, but you'll have, it will be patchy up and down the country. So I think that's something that we're really looking at, and when we publish our universal recommendations, it will definitely be something that is going to be touched on, because I think it's really important.
Thank you. We've just got one hand up, so Natasha, and then we'll move on to our next speaker.
So it's really interesting that you mentioned that, because I'm trying to bring that about within our trust. We're really working hard on that, and one thing I'm trying to instill is bringing this theme across all training, not just one module on one day, but this theme running through everything. So because I think that the challenge is quite often people don't always relate these themes with the clinical, and I think that's where the key issue is. It's that multi-professional approach, looking at how actually these thoughts and feelings and unconscious biases can directly affect clinical care. And I think that's where we're missing the trick at the moment. And I think if we can try and embed it in all that we train, it will make huge differences in culture change.
Yeah,
absolutely. I think it's, I mean, some, you know, may have heard the phrase decolonizing the curriculum. I think the race equality taskforce, RCOG, are doing quite a lot of work on that, and ensuring that we look at just how we teach things, you know, going back to the universities, and then also once people are in their jobs, you know, making sure that we have sort of a universal standard across all trusts and workplaces. You know, I think it's when we look at the statistics, we like, it's something that we can see as definitely, and if we start to address it, as I touched on earlier, you know, for, you know, there being racial discrimination playing a part in these health inequalities, therefore it becomes imperative that we tackle it with something like this, with the education. It has to be so, but I think it's about naming it first of all, so that we can then push for that standard across the board.
Thank you. I'm going to draw that to a close. Apologies, we're tight on time, but that was amazing. Thank you both.
Thank you very much for your time this morning.
I'm
going to have to shoot, so I will leave my contact details in the chat for anybody who wants to reach out. But thank you so much for this morning. It's been really, really inspiring.
Thank you, Melissa.
Thank you, guys.
Thank you so much, Sandra and Melissa. And anybody who would like to donate, Birthrights is a charity, so you can go onto the website and donate to this very worthy cause. Thank you so much. I'm sorry we haven't got longer to ask questions.
No problem.
We will move swiftly on. So our next speaker is Josie Dickerson. Josie is the director of the Better Start Bradford Innovation Hub and Bradford Inequalities Research Unit. Josie's research focuses on integrating research into practice in order to improve quality of care, reduce health inequalities and enhance the evidence base of interventions in practice. Josie also leads the world's first experimental birth cohort born in Bradford's Better Start. Welcome, Josie.
Thank you. Eugene, I'm hoping that you're going to do my slides for me to make life a bit easier. Thank you. I mean, this morning has been absolutely phenomenal, really thought-provoking, really difficult to listen to, as many people have said, but quite inspiring as well. And I think it's really hit home to me. So a lot of work that we've been doing over the last few years has been on looking at inequalities in perinatal mental health, in terms of women's feelings of being able to disclose, in terms of identification, and also in terms of accessing treatment. We've been focusing on perinatal mental health because of my sort of area of expertise, which is in the early years, and it's the impact of perinatal mental health both on mum and her ability to, sort of support her child and her family, and the potential impact that can have on children. But hearing everything that people have been talking about today, there's very little of what I'm going to talk about that doesn't seem to echo right across maternity and the wider inequalities that we've been talking about here. So for me, that's been really useful, and I think it's something we can come back to at the end of my presentation, which, by the way, I'm going to try and do within 15 minutes so that we don't go over, because lunchtime is the most important part of the day, isn't it? So the next...
Interrupt. Did you want the Menti question to come up first? We've actually managed to share it. If anyone that's already logged into Menti, the question is on there that you wanted sharing at the beginning of your presentation. So we can put it up on the screen if you need us to, or people can just log into the Menti and have a look now.
Yeah, you can just have a look if you want, just because of time, really. But I think, yeah, my first question was around just sort of thinking about those barriers around inequalities for especially around perinatal mental health. But my next slide, please. Okay, so this is just over the last couple of years, as I say, we've been doing a lot of work right across West Yorkshire with the West Yorkshire Health Partnership, and it's also linked into the Inequalities Research Unit work that we do, and also with the Better Start Bradford work that we do. But really, we've done a really in-depth dive into understanding who experiences inequalities in perinatal mental health, why these inequalities might be happening, what's happening within the system that is causing some of these inequalities. And we've done that by looking at perspectives and experiences of both healthcare professionals, the voluntary sector who are very much involved in this, but also we've managed to do some really in-depth interviews with women from ethnic minority groups, and many of them in women who don't have strong English language ability, and that's been hugely insightful. And now the conclusion of all of this is what do we need to change to reduce inequalities in the system? So if we move on to the next slide, I'm presenting at the moment. Sorry, it's been. Oh, sorry, you'll have to keep flicking. I didn't realise it was on it. There we go. So just to be really clear, when I'm talking about the perinatal mental health, it's around these issues in pregnancy in the first year after birth, including common mental disorders and also more severe mental disorders as well, like psychoses. Our focus here has been very much on perinatal mental health in pregnancy and the person who's giving birth. We know that there are, groups that wouldn't particularly want to self-identify as a woman, and that there are perinatal mental health issues in partners, but we had to focus to get a really good piece of work in particular element. And just as a heads up, when we're talking about inequalities, we're very aware that obviously there are huge inequalities in ethnicity, in migration, in women's spoken language ability, but also in socioeconomic disadvantage. And that's something that's come out very strongly in our work as well. And just to raise it, because it's one of my biggest bugbears, is that prevalence of perinatal mental health everything is an estimate. Nobody has any idea what perinatal mental health levels actually are in any community, any group of women. So how on earth we're supposed to start to tackle inequalities when we don't know that is a huge challenge and something that really does need to change. So we move on to the next slide. Okay, and just in terms of this pathway, we talk about identification, which is usually undertaken, well, it's commonly undertaken by midwifery, health visiting and GPs, using those sort of short screening questions. If there's any concerns, then the idea would be to go on to assessments using clinical tools and clinical judgment. And referral and treatment would then happen into perinatal mental health specialist services and voluntary sector services as well. So who experiences inequalities in perinatal mental health? And that's in terms of identification and treatment. Well, a lot of women, but what we found from the research literature and from looking at the data within our birth cohorts here in Bradford and across the region using maternity data, is that women who do not speak English well are very, very likely to not have their mental health problems identified, to not access treatment in the same way that other women have. Women who are from ethnic minority groups who can speak English are also much less likely to have their problems identified and treated. Women who are recent migrants also struggle, and we know that refugee and asylum seekers obviously fit into a number of these sort of inequality categories. Interestingly, in Bradford, when we've looked in deprived areas, one of the highest levels of perinatal mental health reporting of symptoms in research comes from white British women who live in deprived areas, but they are much less likely to receive treatment. So there are a lot of disparities there, and actually there may well be more, but there's simply not enough research being done that identifies those. So there may be ones by age, by parity, by disability, but there's just not enough evidence there to be able to talk about those in particular. And why are these inequalities happening? Well, we looked across the pathways of, sorry, if you go to the next slide, of the system in West Yorkshire. I mean, don't worry about this map in particular, or it's just there to emphasise that it's really complicated. And women who live on the boundaries of services, there's a risk there that things might not be always equal. So, you know, a woman could be living, for example, and receiving service from a maternity service in Calderdale, but she could be receiving her health visiting from either Calderdale or Kirklees, depending on where her postcode is. And women on the Craven side of Bradford could have a Bradford GP, but a Harrogate health visitor and an Airedale midwife. So there's all of these sort of, you know, barriers. It's not just a simple place where one can go and get all of their care. And the next slide also shows that the system is inconsistent. Don't again worry about these dots, but basically what they are showing is that in each area there are big differences in the services that are available for women around perinatal mental health. There are different levels of connectivity. So the closer these dots get together, the more the sort of partnership working is around there. So there's better and bigger services in some areas than there are in others. And the referral pathways, thresholds for referrals change per guidelines at every sort of care practice. And the use and interpretation of assessment tools changes between guidelines and between sort of healthcare professionals. And the offers of specialist support in universal and specialist services does differ as well. So whilst most areas would have a specialist midwife, their perinatal mental health midwife, their actual role is quite different. Some have specialist perinatal mental health visitors, some don't. So if we move on again, what I wanted to focus on just for a few more minutes is the women's experiences of these inequalities. So we interviewed 20 women from ethnic minority backgrounds and many women who did not speak English. And we had an amazing researcher in our team, Rifat, who did a lot of interviews in Urdu and Punjabi. So a lot of I'm not going to read the quotes out so you can be reading them whilst I'm waffling on, but there were a lot of practical barriers that were identified by women as to how hard it was for them to engage in services. And this is where I feel this is not just about perinatal mental health, actually, is it? This is about services and inequalities in general. But obviously financial barriers, if women are on asylum seeking budget, you can't afford to travel places, to go to appointments. access to childcare where people are isolated, and if you can't always take your other children with you, then how can you possibly go and receive these services? And geographical locations, so having to, you know, once you get into specialist services, they're often an awful long way from where you live. On the next slide, we talked about relationships and knowledge of services. So a lot of women felt like they wanted specific support, but they didn't know if it was available, and it wasn't necessarily offered to them within the services. And I think, you know, just sort of offering increasing of medication rather than offering the right sort of other options there. And just to highlight, we all know midwifery does an amazing job. I think everybody's been saying that this morning, but in very challenging circumstances. And some have built amazing relationships and made women feel really able to talk about their concerns. But obviously that's not always possible. And the next slide again goes back to something that's been a very common theme this morning. So women, it was really interesting. Sometimes women saw a healthcare professional from the same cultural background as them as a real positive because of that sort of understanding of the cultural issues and just that kind of a ground from which to build a relationship. Others felt that sometimes that was a barrier. So, you know, the sort of an assumption that, you know, maybe they'll sort of dismiss things if it's always like that, or that concern that because of it being a tight-knit community, that if they happen to know somebody else in your family, that then it's, you know, there's concerns around confidentiality and other people knowing about personal problems. And that was a very common thing that came out in our work. And finally, attitudes. And, you know, oh, sorry, it was just that bottom quote there. It's come up time and time again this morning about that sort of institutional racism and women really feeling like they were being judged, and that made it much harder to disclose issues, to access services, and to feel like they were treated fairly. So moving on. We then pulled together all of this research and delivered 2 expert panels with participants from across West Yorkshire, where what we wanted to do was translate these findings into recommendations on how we could reduce inequalities in perinatal mental health. We pulled in specialists from across the area, from a range of different organisations and backgrounds, and came together. This is a very new sort of pulling together of the findings that we had from that day, but what we've come up with on the next slide is 10 key recommendations. And as I've said, I think that actually many of these will echo across other inequalities within maternity services as well. So I'm not going to go through all of these in detail. I would have loved to, but I feel like we've not really got enough time. But if we move on to the next slide, we've got the first key theme that came out was perinatal mental health needing to be viewed as core business, so that there is that level of understanding right at the top and all the way down about the stark inequalities that are there in perinatal mental health care, but actually, as we've seen today, across maternity care as well. And a commitment to additional funding and staff capacity to address these inequalities. And if we can't get that change in the system, as we've been talking about today, we're not going to be able to do very much on the ground to make that change. And enhanced partnership is a real strength, and building on existing assets and the huge value that voluntary sector can play in sharing, learning and developing things. And this shift in service provision to focus on supporting the most vulnerable women. So instead of the service being designed for the 80% of women who are there and doing okay, to actually just rebuild it based on those that are in most need. And just having perinatal mental health as a standing agenda item on every sort of team meeting, every conversation, that is always at the forefront of people's minds. I would just like to say at this point, I should have said it earlier, that a lot of these recommendations have come from examples of good practice that are already in existence across West Yorkshire. So we're pulling on where things have worked really well. Next slide. So this was thinking about equitable services, and this goes back to that slide where I was talking about the differences. So obviously commissioners and special services need to kind of commit to thinking about a shared service offer across areas, especially where there's overlap of borders and different services. But then obviously maintaining that flexibility based on local need, because we know that communities vary hugely. Thinking about services that can be aligned by looking at gaps in the current offer for populations, an overlap of current services, and equity for women who are living on those organisational boundaries. And I do know that a lot of work is being done on trying to do this across the region at the moment. In terms of consistency in guidance, service delivery, referral pathways, I know again there have been new guidelines that have been developed locally and across the region, which is an amazing thing. But I think just our reflections were that there's not always consistent and clear referral pathways that are written down in guidance and in training, and eligibility criteria tends to vary or is not very, very sort of clear always. Something that came up was about branding additional specialist support under the same sort of service umbrella, so that women didn't feel that it was something new or different, that it was just part of their usual support, and making it consistent practice to allow children to be with the mother, which I think it is in the majority of cases, but then making that really clear to women as well, so that they know that they can bring their children along. The next one was around development, commitment, routine staff skills training, and this is something that's come up time and time again today. I think one of the key things that came out here was around cultural awareness, but specifically relating to perinatal mental health, and actually all of the stigma and shame and personal expectations that happen with women of all different cultures when it comes to perinatal mental health, and the fears of that. So understanding how to address those, but within that perinatal mental health arena in particular, and the cultural humility, which is again something that's come up, but not being afraid to ask, is like, I don't understand this, or what does this mean to you or to your family, and really sort of having the confidence to be able to do that. And one of the key things that came up in here was that interpreters need this training as well. You can't expect interpreters to be doing perinatal mental health screening and assessment without them understanding what that means, or how to ask those questions in culturally acceptable language. So pre-translated, tools and for them as well. And that's absolutely key. And it feels to me that that's key right across care for women. If you go on, we'll just flip through a few more of these. Information provision, I mean, it sounds obvious, but just thinking about co-producing letters so that they do use culturally validated language. The word that came up again and again is stop using the word mental. We can talk about well-being, we can talk about challenges, but it doesn't have to be. There's so many. It's a word that's difficult to translate, and it's difficult to interpret in other cultures as well. Thinking about different modes of information, thinking about positive case studies from women who are like your community, and trying to just make services look like a really safe place. Next slide. Additional key support roles came up, and I think it comes back to the doulas and what an amazing job they do for women, but there's something about a support role here, and it feels like it would overcome quite a lot of the inequalities in other areas as well, but it's somebody that helps women to navigate the system, gives them confidence to access these services, removes a lot of the practical barriers so that they're not missing appointments or they feel they can't reach them, building trust and empowering women about their preferences. And I know that doulas do a lot of that, but thinking about this as a more integrated maternity role would be phenomenal. There is a clinical engagement, access and inclusion coordinator in Leeds who does sort of a lot of this work and outreach work, specifically around perinatal mental health, and that role seems to be having a phenomenal impact in Leeds. Longer appointment times for vulnerable women. We've already talked about this. We've already talked about the continuity of care and the value that that can give. But research that we've done with here in Bradford has shown that actually that continuity has helped to do disclosure of perinatal mental concerns in women from deprived and ethnic minority backgrounds. With anybody who needs an interpreter should have a longer appointment time to be able to cover everything. It kind of really, really can't overemphasize the importance of that. The next one was a skilled and equipped interpreter workforce. I don't want to skip over this because it's one of the most important things, but I've already mentioned some elements around that, so that's something that we can follow up on. The ninth one is a meaningful change in data capture and sharing. It's not something that always comes out as obvious, but we don't capture inequalities in our data, so we don't always know the ethnicity, we don't know women's spoken language ability, we don't know their migration status. If we don't know that, we can't understand the inequalities. Sorry. Yeah, I know, I'm sorry, I'm nearly finished. And also there needs to be a better flow of this data, and also we need to be capturing that the actual outcomes of assessments, which is not always the case across all systems at the moment. And the final one, number 10, was about a campaign within the community about understanding awareness of perinatal mental health. We know it's not just a woman, it's a family thing. And so raising awareness, normalising it in a way that takes away that stigma and shame could have a huge impact. And the last thing I wanted to say, I'm sorry, well, I tried to do it as quick as I could. And my final slide is that obviously we know there's a huge amount of work to be done on inequalities. It's not going to be an easy fix. And I just love this Chinese proverb. It's like the best time to have planted a tree was 20 years ago, but the second best time is now. And it really feels like this morning has given us the ability to push and drive forwards on this. So thank you, everybody.
Josie, thank you for that. And I think what struck me from this morning is all the topics. 20 minutes doesn't do justice for any of them, really, does it? Because they're so important. And I think we could spend a whole day on perinatal mental health and the impact that it has, not just on the woman, but on the whole family, you're right. And it's certainly been a real priority for us through Better Births around perinatal mental health. And I know Ruth's involved as well, and Abby's done a lot of work around that and how we really focus on that postnatally, because it's not just about the birth, is it? It's what happens afterwards and how we make sure that women stay healthy, because that impacts on the baby, the rest of the family. So thank you for that. It was really thought-provoking and lots of chats coming in. I'm not going to dwell too much. There's a few things I just want to say to sum up. One, I want to say thank you to all our guest speakers and all our guests for joining us. We've had a huge turnout, more than we'd hoped, so it's been fantastic. Clearly, this is a topic that generates a lot of discussion because it impacts on everything we do in that journey for the women. I think one of the things for us, and speaking on behalf of the Better Births team, is trying to address the inequalities in health is an absolute top priority because it impacts on everything else. And if we can do that in collaboration with others, not just across Bradford district, Craven, but actually across and share learning across the country, which I think we've got guests from all over, which has been fantastic, is a real opportunity for us. And Josie, I can't agree with you more about the tree planting. There's lots of things we should have done 20 years ago, but actually we've got an opportunity now and we're well informed and we understand the data. So there's something about what do we do? It's the so what question now, isn't it, that we've got to answer, and doing tangible things. So I'm going to draw it to a close. I think there's just one last thought for me, and it was all the conversation we had about kindness, compassion and human touch, and it really resonated with me, and not just kindness, compassion and human touch for the people we look after, but for each other. And given all the events around the world at the moment, my thoughts are with all of those who are impacted either directly or indirectly by the events, which are terribly sad. But actually caring for each other at times of stress is really important. So I'll leave you with that thought to take away, to apply to how you work and how you live, with a big thank you from all of us. I just want to check, Abby, is there anything else you would like to add?
I've just put a comment in the chat just to say I'm really sorry that we've not been able to cover as much of the Menti as we'd have liked. There's just so much content today, and as I said, we could have filled a full day, but any questions that anybody has, feel free to forward them to me and I will send those across to the speakers, and we will share all of the content from today as well.
Lovely, thanks Abby.
Thank you.
Amy, anything that you would like to add?
Just want to say a huge thank you to all the speakers and also all the participants. I think it's been a really thought-provoking session this morning. So just a big thank you.
Lovely. Thanks, Amy. Mark, I'm going to come to you for one last thought and then I'm going to say bring it to a close.
Thanks, Amanda. Yeah, two very quick things. One of which I've put in the chat, which is obviously a massive thanks to everyone that's organised this morning, that spoke this morning, that's done presentations. Because to be candid, it's not often you leave a 3-hour-long conference thinking you scratched the surface and you want more, and you want more time to discuss and debate what needs to be done. So that's to everyone's credit, I think, this morning. And then obviously the second thing to say is that, so we've heard a lot of sort of high level stuff this morning, haven't we? National speakers, local work that's been going on. So our job now is converting that, isn't it, into the real stuff, into the work programs, into the specifics, into the measurables, into the change, into the things we want to see different across our place. And obviously that's what, with Abby and Amanda's leadership and everyone else who's on the call this morning supporting, we'll be trying to do through this programme of work. So we're really excited to carry on working with everybody and locally and across the country actually that's spoken this morning. So looking forward to that. Thanks everyone.
Thank you. Right, with that we will draw it to a close 4 minutes after time. So thank you everybody, and have a good day.
Thank you everyone.